Can you turn the microphone on, please?
Current unemployment rate, the most current one we have is from August, and it is 3.2. And we are tied with the state of Maine as the 11th lowest unemployment rate in the United States. The United States unemployment rate is 4.3. The average number of weeks of unemployment insurance benefits claimed by Wyoming workers remained unchanged from last year at 10.3 weeks. From 2023 to 2024, mining, which does include oil and gas, had the greatest increase in UI benefits paid. It increased by 1.4 million or 56.8%. And I did attach to our memorandum an article that comes from the Wyoming Workforce Annual Report. And this article just kind of goes through UI claims for the year of 2024, if anyone is interested in that information. And so moving on to the memo and talking a little bit about conformity with federal law. Unemployment insurance is a federal-state partnership based on federal law that is administered by state employees and state law. The federal law establishes UI requirements, including broad coverage and benefit provisions. Businesses in states whose laws are in conformity with federal law receive credits for their federal UI taxes. Currently, the maximum federal UI tax is $420 per employee per year, but this is reduced to $42 if the state is in conformity with federal law. The memo does list the kind of key conformity issues that there are. Moving on to UI benefit amounts and weeks. Not all UI claimants are eligible for 26 weeks of benefits. And if you were to look at the article that we provided on page 33, there is table 5.4, and it shows that in 2024, 52% of claimants were eligible for 26 weeks, 25% for 20 to 25 weeks, 14% for 15 to 19 weeks, and 7% were eligible for 10 to 14 weeks. Generally speaking, the higher your salary and the more that you work, the more UI benefits you will be qualified for. And this is because of Wyoming Statute 27.3.304, which states that UI claimants' maximum UI payment for a benefit year is the lesser of either 26 weeks at the individual's weekly benefit amount or 30% of wages for insured work in the base period. And you can see this language on page 2 of the full bill, lines 25 through 26. I also attached to the memo some examples of differences and how many weeks of UI benefits someone may be entitled to. So on page 2 of what we call Wyoming Unemployment Insurance Benefits Scenarios. On page 2, there are 2 different claimants. Each of these claimants received 16 weeks of UI benefits during a base period. And what a base period is a 12-month period, and it's the last 4, I always say this a little bit wrong. The base period is the first 4 of the last 5 completed calendar quarters. But whenever we say base period, that is a continuous 12-month period. So here we have 2 claimants. They each received 16 weeks of UI benefits during this yearly base period. The first claimant makes the state average hourly wage, which is $29.60 an hour. And the second claimant works for, in the mining NAICS code, the North American Insurance Classification System. And that average hourly wage in Wyoming is $51.10. And so the first claimant would only be eligible for 20.7 weeks of UI if they were to claim UI in the next year. And then for the mining employee, that employee would be eligible for the full 26 weeks. On page 3, there are 2 UI claimants, each making $15 an hour. The first one worked 35 hours each week, so for 52 weeks in that base period. And the second claimant worked 35 hours a week, but was on UI for 1 quarter, which is 13 weeks. So the first claimant was eligible for 26 weeks, and the second claimant was eligible for 22 and a half weeks. If the first claimant was working 40 hours a week, he still would have been entitled to 26 weeks, but his benefit amount would have increased by about $40 a week. So he would have made a little bit more because he would have made more money during that base period. And then the last 2 scenarios each involve claimants who had received a full 26 weeks of UI benefits. The first one makes the construction average hourly wage of $34.10. And the second one is in the mining industry, making $51.10. The first claimant would be eligible for 17 weeks, and the second claimant for 23 and a half weeks. So, I mean, this isn't the first time that this bill has been in front of the legislature. And, you know, I do listen to the hearings, and I hear a lot of different things. And today just kind of wanted to provide some education and some information that maybe seems to kind of be missing in some of those discussions. So that is just to kind of illustrate that not everyone is eligible for 26 weeks, and to also show how individualized each particular claimant's weekly amount will be, because it's all based on how much they've worked during that 12-month base period. And then I wanted to talk about the Reemployment Services and Eligibility Assessment Program. The DWS started this program in June of 2023, and the program is aimed at accelerating the reemployment of UI claimants and ensuring continuing weekly eligibility. And the continuing weekly eligibility means every week someone claiming UI has to be eligible. And to be eligible, you have to be able and available for work, and you have to be actively seeking employment. So the program looks at that, and I'll explain that a little bit in a little bit more. But what happens is that our UI division has developed an algorithm, And so it develops a list of the 40 UI claimants each week who are the most likely to be on UI for the longest period of time. And then this list goes to our workforce centers. And the claimant, these 40 claimants need to make an appointment by the following Tuesday with our workforce center. And then when they meet with our workforce center, we work on improving job search skills, making sure that they understand how to look for jobs and the best ways to do so, help in identifying strengths and weaknesses, discuss and review any job opportunities, and then the one-on-one assessment of UI eligibility to make sure that they are able and available to work, as well as actively seeking work. They can develop a reemployment plan and provide customized labor market information for that claimant. We do receive $500,000 from the United States Department of Labor every year to run this program. And on Wednesday, we received an award notice that gave us a performance bonus payment of an additional $100,000. So we believe we'll be able to reach out to now more than the 40 claimants that I mentioned before. Don't know exactly how many more we may be able to add to that list, but it should be more than we are currently able to do. There is also information in the memo just about UI eligibility, kind of going through each one of those in a little more detail, a little bit about how UI tax rates are calculated, talks about the CARES Act deposits into the UI Trust Fund, the current balance of the UI Trust Fund, and the amount of interest that is earned on that fund. And with that, I stand for any questions.
Thank you, Director. Committee, any questions of the Director on her memo or regarding the bill draft? Senator Hutchings.
Chair, Mrs. Gagan, on the this on page 33, this is telling me and I'm assuming this is for Wyoming. Ages 25 to 54, you have more people on unemployment than any other age bracket. Is that true?
Director?
Madam Chairman, Senator Hutchings,
On the
Oh.
age?
on the age, I believe it's the demographic of 35 to 44, but only by a little bit.
Still,
Only by a little bit.
the pretty much normal working age, you have more people not, or more, a lot of people on unemployment. That's what I'm asking.
Director?
Madam Chairman, Senator Hutchings, yes, but in order to be eligible for UI, you had to have lost your job. You had to have lost your job. And then some of those eligibility requirements is you couldn't have voluntarily left your work. And you can't collect unemployment if you were dismissed for misconduct.
Thank you. Further follow-up. Senator
Follow-up,
Hutchings.
Madam Chair, thank you so much. Somewhere in your conversation, you were mentioning 40 claimants. What was that all about?
Director?
Yes.
Thank you.
Madam Chairman, Senator Hutchings, the 40 claimants that I mentioned were part of our reemployment services program. And so every week we have an algorithm and it picks the 40 claimants who are the most likely to remain on UI for the longest. And we provide, and these are mandatory appointments and services that we provide to them. So in order for them to continue to be eligible, they do have to meet with our workforce center staff and again, prove that they are eligible for UI benefits and work with our staff on a reemployment plan.
Quick follow.
Follow-up. Senator Hutchings.
So your algorithm selects 40 people out of almost 8,000 or 8,000, 7,000 people?
Director?
Thank you.
Madam Chairman, Senator Hutchings, good question. That is for every week. So it's 40 new claimants every week.
Thank you.
Further questions? Representative Thayer, did you have one or no? Okay. Seeing none. Director, thank you for joining us. Thank you for your memo as well.
Thank you.
All right, we'll move on to public comment on the bill draft, unemployment insurance coverage. If you'd like to testify on this bill draft, please come forward. Got 3 chairs up here. Good afternoon, welcome back.
Madam Chair, thank you. Jeff Doherty again appearing on behalf of FGA Action. And I want to just thank the director for that phenomenal report. I thought it was really helpful. Madam Chair, members of the committee, speaking in favor of the bill today, as you know, this is a bill that's come before you. I think this is a 4th iteration of this bill, and we've tried it in a couple of different ways. We tried indexing to where the lower the unemployment rate is, the less time you get, and the higher the fewer weeks you get, and that turned out to be pretty confusing. So last year we ran a bill very similar to this bill, including the reemployment language in it and renaming the department and things like that. And it ended up not surviving, I think it was 2nd or 3rd read in the House. And the reason for that was some of our friends within the unions had concerns with it. So I spoke with my colleague who represents some of the union folks here in the community, asked her what her major concerns were, and chief among them were what we might refer to as work attached. And what that means, if you'll imagine, say a highway road builder, and they work from, they send you home in November when the snow starts to fly, and then they bring you back in the spring. For highway folks, the temperatures need to be 50 degrees and rising in order to lay asphalt. So depending on the length of the winter, they may not be able, as badly as they may want to get back to work, it's just a factor of temperature that allowed them. So I am suggesting the language in 0.0. I think it begins, I gave my copy to Senator Hutchings, but I think the amendment begins on page 2, line 19, and then it goes page 3, line 2. And effectively what this does is it exempts work-attached individuals from the decrease from 26 to 20 weeks. And Madam Chair, our objective is this. We believe work is a blessing, and we believe it gives individuals purpose. And we understand that unemployment occurs, but our goal is to try to get people back to work as quickly as we can. And members of the committee, I'd have you know that we have studies, including a Federal Reserve study, that found that the longer someone was unemployed, the less likely they were to become reemployed. And so it's really vital that we move things as quickly as we can when folks are in this situation to try to get them back to work as quickly as possible. Right now, our research, and I'm not contradicting the director, our research is we show about 11 jobs open for every UI recipient. And obviously not all those match up perfectly for the employees, right? But the fact of the matter stands that we do have work opportunities and employers who want workers, and we have to make sure that the right incentives are in place for the workers so that they'll come and take those jobs. Our second hope in bringing this is that it reduces your exposure on your unemployment trust fund. We hope that by reducing the number of weeks that are liable to the trust fund, that it in fact reduces the liability of the trust fund, which brings me to my final point, Madam Chair, in the hope that at some point in the future, we can adjust the amount of money through separate action, not this bill, but that we can adjust the amount of money that employers are paying in, because for many employers, that's a barrier. The amount of money they have to pay to hire employees is a barrier to some employers from hiring people. So the more we can economize that, we think the more robust hiring will be and the better our economy will be. So Madam Chair, in the interest of time, I'm going to pause right there and see if there are any questions.
Thank you, Mr. Daugherty. Questions? Representative Ottman.
Thank you, Madam Co-Chair. Mr. Daugherty, I always have trouble. On page 2, I have read this, and I'm sure it's correct, but the way that I read it, it says, except as provided, maximum amount of benefits payable to any eligible person in a benefit year shall not exceed 20 times the person's weekly benefit. I'm like, 20 times? Is that even a possibility that somebody would receive 20 times their weekly benefit? Or do you mean 20 weeks?
Madam Chair, and
Mr. Daugherty.
the director may be better situated than I, but as I understand it, the 20 times the weekly benefit, that equates to weeks. So, 26, you have 52 conceivable pay periods within a calendar year, right? So 20 times your benefit should be 20 weeks.
Madam Chair.
Follow up, Representative Ottman.
Okay, so anyways, and maybe the director needs to speak on this, but honestly, that 20 times the person's weekly benefit, that's very confusing to me. I hope that we can fix that and just say, shall not exceed 20 weekly benefits or 20 weeks of benefits, the person's, rather than 20 weekly benefit. So anyway, that's just me. Maybe it doesn't bother anybody else, but.
Thank you.
Further questions, committee? Senator Hutchings.
I'm trying to figure this whole thing out here. So we have someone that, I'm looking at the industry thing on her little draft here of people, different industries and how much UI they get, the recipients get. So if I'm a construction worker and I'm working from spring, May to September because of the weather. So that means I have from October to April where I'm not working. And maybe the director wants to come back up on and help answer this, but so I'm going to get unemployment for those weeks that it's winter time. And what I'm trying to figure out is, why am I getting unemployment instead of looking for a job for the winter? What can be done instead of giving people an incentive not to work for me, I would plan, hey, you're not going to be working from this time to this time, work where there's work. So do you have an answer for that?
Mr. Daugherty.
Madam Chair, Senator Hutchings, thank you. Thank you for that question. It's actually a really interesting observation. And I will tell you, I'm recommending the amendment to help with the passability of this bill. But anecdotally speaking, an example I would share with you that might illustrate the point you're trying to make is, I think about our friends over in WYDOT and what a struggle they have every single year trying to recruit snowplow drivers during the winter. And one of the things that I would point out is, if you're in a training program, then the work search requirement is waived while you complete your training program. So therefore, if you're working through your way to get a CDL, for example, so that you could go plow snow for the Department of Transportation, I would think that's a fantastic way to spend the winter. But again, this is my best effort at trying to get this bill passed and trying to provide some comfort for our friends in the unions. Is that helpful?
Committee, further questions? Senator Scott.
Madam Chairman, just want to make sure I'm understanding this bill properly. Is my understanding correct here that all this is stuff that is permitted within the federal regulations governing unemployment insurance, but none of this is stuff we have to change to stay in compliance. In other words, it's not mandatory stuff. Is that a correct understanding?
Mr. Daugherty.
Madam Chair, Senator Scott, I would tell you, you may pose that question to the director. They may have a better answer than I. If not, I can certainly have my team at FGA research that and we can get it for you.
Madam Chairman,
Senator Scott.
I do hope we'll eventually get an answer to that either from the director or somewhere else, because I don't like the name change and there's some other things I don't like in this bill. But I want to know if there's any mandatory federal compliance here. I wasn't clear on that.
Okay, well, the director is walking back up, so perhaps she has an answer for you, Senator Scott. Director?
Madam Chairman, Senator Scott, nothing in the bill draft is mandatory for federal compliance. Also, the bill draft was reviewed by the Department of Labor when it was introduced the last time, and they told us that it didn't cause a conformity issue. I haven't seen the amendment, so I can't speak to the amendment, but I'm certain that it's not something that needs to happen to be in conformity with federal law.
Further questions of Mr. Daugherty? We've got one, Representative McCann.
Thank you, Madam Chair. There seems to be more of a carve out for their, I forget what you call them, but the seasonal workers, work attached. Is there a dollar amount attached to that as far as, okay, if we keep everybody at 20 versus that carve out for the 26 weeks? So we can get an idea of like, okay, how much are we really talking about here?
Mr. Daugherty.
Madam Chair, I didn't do a financial analysis. That may be information the director may be better able to provide to the representative.
Thank you. Director, if you would like to answer that.
Madam Chairman, may I ask a follow-up question? Representative McCann, was your question with regard to the amendment or to the original bill?
Representative McCann.
Thank you, Madam Chair. I'm not sure if I'm being clear. I know it's in my head. Maybe I'm not saying it right. We have a standard 20 weeks for the unemployment insurance. And we're trying to keep our work attached people in state so they don't go somewhere else in order to fill those slots when their seasonal work, for lack of a better term, comes about. Is between that 20 weeks and that 26 weeks for that people, is there a dollar amount that we can roughly get at? Does that make sense? Sorry.
Director?
Madam Chairman, Representative McCann, we could probably find that number. I think I understand what you're asking. I don't know what it is right now.
Committee, any additional questions for Mr. Daugherty? Okay, thank you, sir, for joining us. Any additional questions for the director? Senator Hutchings.
Thank you, Madam Chair. I don't know if I heard it correctly. Did you say the average person stays on unemployment for 10 weeks? Did I hear that?
Director?
Madam Chairman, Senator Hutchings, that is correct.
Thank you.
Further questions of either? Okay, see none. Thank you, Mr. Daugherty. Director, thank you. Okay. Further public comment on the bill? Okay, see none in the room. Any online? Okay, none online. I will close public comment on unemployment insurance coverage bill draft. Committee, what is your pleasure on this bill? Okay, the bill has been moved by Senator Steinmetz. Second by Representative Ottman. Discussion and amendments. Representative Yen?
Madam Chairman, no amendments, but to speak on the bill, we had this bill, it died in the House floor on third reading, 36 to 26 or something like that. So I'm curious on if there's an expectation that it's going to survive this time and what that expectation has changed? And why push for so many sessions to take away unemployment benefits from people who worked for them?
Further discussion on the bill or amendments? Senator Steinmetz.
Madam Chairman, I would like to move the amendment on working draft 0.0 to amend page 2, line 19 through 2 on page 3, that language in, and any other conforming amendments that are provided in 0.0 draft. I think that takes care of the seasonal worker issue, the worker employment attached folks. And as we have heard to Representative Yin's question, that seemed to be the problem on the floor last time. And so hopefully that would allay the concerns that were brought up.
Is there a second? Second by Senator Brennan. Discussion on the amendment.
Madam. Okay,
Representative Thayer.
Thank you, Madam Chair. I voted, excuse me, against this because of multiple reasons. Our seasonal workers, this new amendment perks my interest. I guess the question would be in the B component, it would be benefits payable to any eligible individual. It's a little ambiguous, and I know we have time to work on that. But I mean, that is something that, like, what is the definition of eligible individual that could go back to 26 weeks?
Thank you, Representative Thayer. Ms. Johnson, do you have any insight on that?
Madam Chairwoman, I was actually going to ask the committee to maybe give me permission to figure out a definition of attached to regular work. I mean, I think I know in concept what it's supposed to mean, but I don't think it's very clear in statute as it stands right now in the amendment, like what that would actually mean. I mean, I know it's supposed to be like a seasonal employee or something along those lines, but I think you probably do need a definition of attached to regular work to make this more clear. And if the committee would give me leave to put in a definition of that, I think that would be helpful.
Thank you, Ms. Johnson. On the amendment, continuing on the amendment. Senator Brennan.
Thank you, Madam Co-Chair. I just want to, I think that this is an important amendment if we want to move this forward. I've always been a no vote on this bill, and one of the big reasons is because of the seasonal workers and how that is kind of part of their wages, and that their employers do pay in more to this because of that. So I think that this is an important amendment, and once we get this in, I think looking at kind of that eligible individual would be a great thing too. So I would just encourage us to adopt this amendment.
On the amendment, further discussion. Okay, seeing none, we'll go ahead and vote on Senator Steinmetz's amendment by a show of hands and a voice vote. All those in favor of Senator Steinmetz's amendment, please state aye. Aye. All opposed? Okay, that amendment has passed. Further amendments, further discussion on the bill. Senator Brennan.
I would just propose an amendment that we give LSO latitude to work on a definition for eligible individual on this, I think.
Is there a second for the conceptual amendment? Seconded by Representative Guggemos. Discussion? Okay, seeing none, all those in favor by voice vote and a show of hands of Senator Brennan's amendment, please state aye. Aye. All opposed? Okay, that amendment does pass. Further amendments, further discussion on the bill. Okay, seeing none, we will go ahead and vote on 26 LSO 0141 unemployment insurance coverage period and reporting. If you would call the roll.
Senator Crum,
Aye.
Senator Hutchings, Senator Scott,
No.
Senator Steinmetz,
Aye.
Representative Klauston, excused,
Representative Klauston, can you hear?
Madam Chairwoman, it was my understanding that he was just going to be listening in. I think he's driving.
Okay.
Representative Gugamas,
Aye.
Representative Heft, Representative McCann,
Aye.
Representative Ottman,
Aye.
Representative Thayer, Representative Wasserberger,
Aye.
Representative Yin,
Nope.
Co-Chairman Brennan, Chairman Rodriguez Williams. 11 aye, 2 no, and 1 excused.
Thank you, Ms. Hunter. So that bill draft has passed committee. We will continue to move on. It looks like we have wrapped up number 8 on the agenda, public assistance programs. We will move on now to number 11 on the agenda, which is an update on the big beautiful bill and health insurance. First on the agenda, we have the Wyoming Department of Insurance. Good afternoon. Welcome.
Thank you. Madam Chair, committee members, my name is Jeff Root. I'm the Commissioner of Insurance. With me is our Senior Health Policy Analyst, Jill Reinking. She'll give you the update on the big, beautiful bill, and we'll be here and happily answer any questions you have.
Thank you. Please.
Madam Chair, committee members. As stated, my name is Jill Reinking. I'm the Senior Health Policy Analyst for the Department of Insurance. I'm here to discuss the One Big Beautiful Bill, or OBBB, or HR1, any of those names, and how the changes may impact private insurance and ACA marketplace plans and the DOI's oversight of those plans. I'll go briefly, or kind of quickly, because I want to save us time, but some of the changes are going to be new administrative requirements for enrollment and re-enrollment. At this point, an individual does not have to go in and re-enroll every year. It can be an automatic rollover in enrollment into the next year. That will terminate. Just for an idea, in the last year, 10 million people across the country were automatically re-enrolled. Individuals will have to go on manually and verify their information each year when they go in for enrollment. There will no longer be provisional eligibility for premium tax credits. And part of that will be individuals will have to wait for documentation to be processed. So in the past, what they could do is they could go in, put in their information, their documentation, and they would have 90 days where they would be able to pay the premium at that provisional cost until their verification was completed. That will no longer be the case. There will also be a shorter enrollment period. So starting in 2026, annual open enrollment will still begin on November 1st, but instead of ending on January 15th, it will end on December 15th. A large thing or a large discussion or outreach that we will have to look at doing is making sure that people realize that that has changed. So when it comes time to re-enroll for their plans, they realize they have less time in which to do that. The biggest part of the discussion today is going to be on something that is technically not in the One Big Beautiful Bill, and that is the expiration of the enhanced premium tax credits. There continues to be discussion in Congress about getting those tax credits continued maybe for a year or 2 years. However, at this point, they're scheduled to end at the end of the year. Nationwide premium increases were set prior to that at being around 20 to 25% across the country. individuals in Wyoming were looking at a base premium rate increase of around 20%. Now with the premium tax credit set to expire, some of those same individuals could look at premium increases of 200 to 300%. The reason being is right now, when you receive that premium tax break, you receive that credit towards those premiums. The 20% is just the base, taking into account that you have those premium subsidies. Once those go away, individuals are going to have to realize that their premiums are now going to go up. There's not going to be that subsidy there to assist them with that payment. This could possibly reduce enrollment in private plans, but we're not sure of what that impact is going to be. In Wyoming, I like to use the comparison of if you have a balloon and you squeeze on the balloon, that end gets smaller, but that has to expand into another spot. And so while we'll have people that may be able to afford to stay on that plan that they have selected, it may not be a big enough increase. They feel they can still make those payments. There may be a large group of individuals that decide they can't afford their insurance through the marketplace any longer or through a private plan. So the downside of that is we don't have any way of predicting who's going to keep their plans and who isn't, or who's going to stay on those plans. We don't have any way of predicting if it's going to be the younger youthful group that stay with their insurance plans, which help with rates by being that healthy environment, or if they also are going to drop their plans. So as far as for our department, it's kind of a wait and see on what's going to take place in the next few months. As far as our Office for Outreach, we are visiting with other states that are, of course, going through the same changes, some more drastically than we are. And then with the NIC regarding national changes and recommendations. We continue our communication with the insurers in our state and what they're going to be able to offer. And then we have concentrated our PSA announcements. We are required by statute to do a PSA every month that's published in the state newspapers. We have concentrated the last 2 months and now through the end of the year on health insurance issues. And a lot of that has been directing them on paying attention to what your plans are, taking into account there's going to be these changes, just to kind of give them a heads up that there are those changes coming. And if anyone is interested, those PSAs can be found on our website. We also link them on our LinkedIn page for the public. We also have online a new consumer guide that provides some guidance on what people should look for in their plans and how to go through and review their plans to see if it still meets their needs. And as always, we have a stellar consumer assistance unit, and they're prepared to answer any changes that people may have with regarding their plan. Currently, there are approximately 47,000 individuals that are enrolled in a market plan. And of those, 95% of them currently receive a subsidy. So I would open it up for any questions.
Thank you. Ready? Any questions? Senator Scott?
My questions are on the scheduling of this, and do we have a big cliff that people fall off if they earn too much money? And let me preface it by saying I represent the district in Trumbull County that has most of the rural area. It's still largely within the city of Casper in terms of people, but I do have most of the rural folk. And in the ranching business, often somebody's earnings for the year will be determined by one sale or two sales in November or December. How do they deal with that if they don't know what their income's going to be until then, and don't have trouble predicting what's going to happen? And what are the consequences of being wrong? Can you get into something that I heard originally on some tales in Sublette County of people whose premiums went double and triple and up into the multiple thousands of dollars increase they hadn't expected. Is that still possible? How does that work when when you're close to that 400% of the federal poverty level.
Ms. Ranky.
Madam Chair, Senator Scott, they will, currently now, when you go in and you're receiving your ACA plan, you go in and you calculate what your income you believe is going to be for that period of time. It's then corrected on the flip side when you file your tax returns. So those individuals, when they file their tax returns, may have to pay back some of that money that they received as a subsidy if they exceed what would be allowable under that. Or I would imagine, and I can't say for sure, that if they had paid in more than they were required to, that they would get some back. And again, I'm not positive on that. So it's going to come into each year calculate. They're going to have to give, I would say, their best calculation of what their yearly earnings are going to be when they apply for that plan. And then it'll be balanced out when they then file their tax returns. Sadly, you're right. Within the state of Wyoming, a lot of the people that are on our ACA plans are going to be farmers, ranchers, individuals that don't have your regular monthly calculated incomes. And so it is going to be, I would say it's probably a hardship for them to come around to that point and calculate what they expect they're going to make within that year.
Further questions, committee? Or do you have a follow-up, Senator Scott?
Madam Chairman, but is the penalty limited to just having to give up some of the subsidy they thought they were going to get and having to pay that back? Or is there some other penalties involved?
Ms. Ranky.
Madam Chair, Senator Scott, I believe that right now it was, you would have to pay back up to $5,000. I think there was a cap on how much you would be required to pay back. And that cap will go away within this next year.
Another follow-up, Senator Scott, or are you good?
Within this next year. So if somebody is off for 2025, the cap still is in effect, but for 2026, it isn't? Is that what you mean?
I believe that is, I'm sorry,
Ms.
Madam
Ranky.
Chair. I believe that is correct.
Okay.
Senator Steinmetz.
Thank you, Madam Chairman. So, thank you for the update. And one of the things I'm curious about, you mentioned you thought that this would harm private insurance, but I'm wondering if we might see a resurgence of private carriers with these changes. Is Blue Cross still the only private carrier, or have I got that wrong? How many private carriers do we have in the state now, I guess is my question. And could this in some way help revive that industry? Because when those changes happened, it was a huge change for agents, for companies, for citizens. And if that industry revived, would they have to comply with that only open enrollment? Because people used to be able to change insurance whenever they wanted and had a lot more freedom of choice than they do now.
Ms. Ranky.
Madam Chair, Senator Steinmetz. And I apologize if I stated earlier, I don't know what the long-term effect is going to be for private insurance. We are unable to determine who's going to stay on insurance, who isn't. That is going to be an individual decision, obviously. I'm sorry, so the rest of your question.
Senator Steinmetz.
Madam Chairman, thank you. Sorry, I didn't mean to keep you
No,
confused.
you're fine.
It's been a long 2 days. And no lunch. So, my question was, could it help private insurance in some way? And secondarily, how many private companies do we have left? I mean, because it was a massive change when we did the Affordable Care Act, and for agents, for companies, for the entire nation, of how citizens receive their coverage. So if you could opine on that.
Madam Chair.
Ms. Ranky.
Senator Steinmetz, currently we will have 2 insurance providers on the marketplace. That'll be Blue Cross Blue Shield and United Healthcare. As far as total plan insurers, how many? 800 other plan insurers in the state. Again, it could very well help private insurance until we see kind of how it hashes out with people as far as what direction they want to go and what costs they can afford. It's hard to predict.
Follow-up, Senator Steinmetz.
Just one follow-up, and that is, So really that is what, and my husband's in the business, so he, on his group plans, he's seeing, 19, 20, 30% increases in premium this year, kind of across the board. So are those the kinds of increases people could expect to see on a more private basis, where with the ACA, they could see 200 to 300%? I mean, couldn't that help the free market?
Ms. Rinke or Director?
Madam Chair, Senator Steinmetz, I guess the answer is yes. It's which market we're helping. You have a large, health insurance market. An ACA plan covers many things. It's a comprehensive plan. I think there'll be some people who no longer receive subsidies who can't afford any of those comprehensive plans, and they may just fall back onto catastrophic plans. And so we're not sure how much of that movement will occur, but people who had, I think, some of the best insurance they've had in their life, that was subsidized, when those subsidies go away, they're going to be pulling back and they will not have the coverage they had. And that's just, they know that going in. So, but that will be an outcome. So.
Senator Scott.
Chairman, follow up on all that. As I remember, before the ACA, we may have had a lot of companies registered, but there were only 4 or 5 who were actually selling policies, small group, one most likely affected. And there were some, they had to belong to some particular group, or there were some that were just catastrophic. What's left of the small group market that's going to be available under any companies, more than one?
Welcome. If you'd
Hello.
state your name.
Madam Chair, my name is Tana Howard, and I'm the Deputy of Insurance. Senator Scott, so small group remains the hardest market, right? By far, it has definitely dwindled, and that's been for multiple reasons. I mean, part of it is that small group market it's a smaller risk pool, right? So the premiums have gone up dramatically. And because there's been so much, because of the extended tax credits, more employers they've been less incentivized to maybe offer those small group plans, because you can get an individual plan for minimal or $0. So that small group market has really diminished in the last 10 years. Absolutely. We still do have carriers that are offering small group plans. But it's high. It's definitely the hardest market to place at this point. But we do have insurers. How many insurers we have offering small group plans? Probably, I want to say, of major medical, probably about a dozen carriers right now. I can double check those numbers, but that's a probably educated guess.
Thank you. Further questions? Okay. All right. Well, thank you for joining us. All right, we'll move forward with the next agency, Wyoming Department of Health, providing an update on the One Big Beautiful Bill and health insurance. Welcome back.
Thank you, Madam Chairman, members of the committee. Stefan Johansson with the Department of Health, joined by our Deputy Franz Fuchs and our interim state Medicaid agent, Jesse Springer. Seeing as how you extended your agenda into the afternoon, I'll try to be brief, give you a broad overview of the health, Department of Health related provisions and components of the Big Beautiful Bill Act, or HR 1. I won't go through every single section of the bill, but picked out a few highlights for you. just because there has been, I think, over the past several months, some misunderstandings out in your communities about exactly what the impacts would be on the Department of Health, on Wyoming Medicaid, for example. We'll touch briefly on the discussion that you just had around potential expiration of enhanced premium tax credits on marketplace plans, and then close with a discussion on the Rural Health Transformation Program, as you all have been touching on the past 2 days. So as has already been discussed, the Big Beautiful Bill Act, or H.R. 1, was passed and signed by President Trump on July 4th. Various provisions related to that bill impact health departments and primarily Medicaid programs across the country. And I'll, as I mentioned, pick out a few sections of that. But by and large, the conclusion for your Department of Health and especially your Medicaid program in Wyoming is that we will see relatively minimal impact from H.R. 1 from the Big Beautiful Bill, especially on the financial side. So federal funding changes, different policies that impact coverage, eligibility, reimbursement from the federal government, almost across the board are not impacting Wyoming, particularly because of how we have run our Medicaid program, various policy decisions we have made or haven't made over the years, often with legislative input or direction. So a few sections, Madam Chairman. There's been a lot of discussion about the changes from H.R. 1 relating to what are called provider tax or supplemental payment programs. And those of you who have served on this committee for a good bit of time know that every state Medicaid program uses these types of programs. It's a federal allowance where essentially you take a type of provider, let's say hospitals or nursing homes. In Wyoming's case, ground ambulance has also been recently authorized as part of these programs. The Department of Health assesses a fee to that type of provider. We collect that revenue. We then match it with federal funds and redistribute that entire pot back out to the provider group in a specified format that's federally approved. And the reason for those programs is to increase cost coverage without expending state general funds, but also because generally speaking, Medicaid reimbursement rates are below what we kind of peg at Medicare cost, or what you might hear referred to as the upper payment limit. So without increasing reimbursement rates, you can use those supplemental payment programs or provider tax programs to essentially increase your cost coverage in certain types of provider situations. In Wyoming, that's hospitals, nursing homes, ground ambulance, private physicians affiliated with hospitals, and recently psychiatric residential treatment facilities, of which Wyoming has 2. The reason I linger on that is that there were significant changes from H.R. 1 to those provider tax programs. But again, the takeaway is none of those changes will negatively impact Wyoming or Wyoming Medicaid, primarily because we have always stayed under federal caps or allowances within those types of programs. Other states, who I won't dime out, have not managed that conservatively. And secondly, some states have also used those programs in interesting ways, benchmarking that cost coverage upper payment limit at a certain percentage, and in some cases 200% of commercial rates as opposed to Medicare rates. Federal government and Congress, through Big Beautiful Bill, started to scale that back. And again, some states will see significant changes resulting from that. Wyoming will not. There is provisions that are related mostly to Medicaid expansion states, again, which Wyoming is not. And we won't see any impacts or major impacts from these changes. For example, requiring semi-annual renewals for the eligibility renewals for the expansion population. Again, we do not have the non-disabled adult Medicaid expansion under the ACA. So that won't impact us. Third, I've gotten a lot of questions over the past several months of how Wyoming Medicaid will be implementing the community engagement or work requirements that were part of H.R. 1. But again, that was specific to non-disabled adult populations in Medicaid expansion states. So just to be clear for the record, those requirements do not impact Wyoming. We do not have that type of population on our Medicaid program. And as we discussed yesterday and even this morning, you cannot be on Wyoming Medicaid purely by just having low income. You must meet one of our categorical eligibility criteria. So we don't see any significant impact from that. There's also cost sharing changes for Medicaid expansion populations. Again, no impact for Wyoming. A few things that when we were testifying in front of the Appropriations Subcommittee earlier this week, Mr. Springer mentioned there are some provisions and technical provisions that we find could be very helpful for our operations in the Department of Health and in Medicaid. For example, there's a kind of cleaning up or a standardization of retroactive eligibility. In some cases across Medicaid programs, you could have 30 days, 60 days, and even 90 days of retroactive eligibility from the time that you applied. If you could demonstrate that you were in fact eligible at that time, then once that application was processed, eligibility was made, we could date that back 90 days, retroactively. That has some kind of been standardized through the Big Beautiful Bill at 60 days. Again, I think it helps with standardization across the work that we do in eligibility in Medicaid. And then a few things that I'll just touch on that were sections of the bill. We've talked about a few of them over the past 2 days, so I'll be very brief. But when it comes to verifications of eligibility and periodic re-verifications of eligibility, things like cleaning up the rolls of Medicaid members who are deceased or providers who are enrolled in Medicaid that may be deceased or no longer providing service. There were some sections of HR 1 that really addressed that. And as Mr. Springer walked you through earlier in your meeting, we're pretty advanced relative to other states and the interfaces that we are already using in our Medicaid technology to verify those things. You have had a lot of discussion about Medicaid members enrolled in multiple states. As Mr. Springer mentioned earlier this morning, we have an interface that's been running since June to be able to close cases where we do find individuals who are enrolled in multiple Medicaid programs in 2 or more states. And there's a process now behind that where you send written letters to those members. If they don't respond, the case is closed, or if they provide information where their primary residence is here in Wyoming or on the other side, not here in Wyoming, then appropriate action can be undertaken. And then I also wanted to mention, because you had this discussion on the Department of Family Services side in your SNAP and TANF programs, which were also addressed through the Big Beautiful Bill, similar provisions for Medicaid programs in the legislation around payment error rates and eligibility error rates. So we call that payment error rate PERM in our lexicon. And those eligibility error and payment error standards have been set at 3%. In terms of our payment error and claims processing, we believe that we will be well below that and hopefully not face major penalties, which Mr. Springer can correct me if he believes I'm wrong on that. On eligibility error rates, we are likely close. That's kind of a moving target, but there are provisions of that bill that a certain percentage of the federal allocation of funding, if you're significantly over that error rate, can be clawed back from the states. So it's something that we will absolutely pay attention to. Again, as I mentioned earlier in your meeting, I think we're well positioned with our technology infrastructure to not only be able to comply with many of these provisions, but also be able to exceed them. And last, Madam Chairman, you already had a lengthy discussion about the potential changes to the ACA marketplace, given the potential expiration of the enhanced subsidies or enhanced premium tax credits going on. We also don't know what congressional action will look like between now and the end of the year. There could certainly be changes or renewals at the federal level or not. And similar to Department of Insurance testimony, but a little bit different since we're in the Department of Health, we do not directly control, regulate, or finance anything related to ACA marketplace plans. The reason we pay attention at the Department of Health side is mostly from the health policy perspective and the public health perspective of what those changes to coverage rates or the amount of the uninsured population that Wyoming sees would mean for either our various programs throughout the Department of Health or long-term impacts to the lack of insurance coverage where you could over time see more emergent conditions or long-term care needs, et cetera. But I think similar to what insurance testified to, time will tell on those specific provisions. And we did hear a significant amount of public input and feedback in the meetings we held around the state the past 6 weeks on the Rural Health Transformation Program, that a priority for many of your constituents and community members that showed up to those meetings was to look at better access to affordable health insurance options. Part of that might be from the knowledge of what might be changing in the individual marketplace, or just in terms of health insurance and healthcare cost in general. We know that Wyoming is pretty high on that scale when it comes to the cost of insurance and the cost of care generally. And so it does resonate in the public feedback from community members across the state concerned about the price of their health insurance or the price of healthcare in general. But Madam Chairman, a big conclusion here is that we will absolutely monitor that. I think as part of our Rural Health Transformation Program application, potentially look at some alleviating mechanisms on health insurance costs or health insurance coverage. And I'll get to that here in a minute when we discuss that broader program. But a big takeaway from the Department of Health and specifically Wyoming Medicaid impacts from HR 1, we are seeing pretty minimal impacts across the board. Nothing that at this time we believe will generate a budget request for the department. And again, I think that's a testament to how Wyoming Medicaid has been administered over the years, the choices we've made, some of the choices we haven't made, but also that, this legislature's involvement in, having Medicaid running the way it is in Wyoming has kind of kept us out of the limelight in some of those more impactful changes. I'll stop there, Madam Chairman, before we move on to Rural Health Transformation Program. Number one, see if there's any comments from my colleagues or things that I misstated, and obviously answer any questions you all have.
Thank you, Director. Gentlemen, do you have anything you'd like to add? No? Okay. Committee, questions of the Director. Representative Yen.
Madam Chairman, thank you, Director. I am interested in talking about the tax credits a little bit more. And I hope that we'll hear from some either hospitals or insurance companies, because the idea of us, basically a large sum of money is going to be removed from inputs into our healthcare economy. And so something's going to have to make up that money. Either it's going to be less services or we'll have more uncompensated care. And so someone's going to have to pick up that bill. I'm curious on what you think the long-term economic outcomes for the healthcare of our state might look like. Do you think it's going to affect hospitals? Do you think it's going to affect private insurance rates? Do you think it's going to affect the number of people insured?
Director.
Madam Chairman, Representative Yen, I hate to speculate on all of those measures. I think each one of those factors you mentioned will probably be at play if the enhanced premium tax credits do end up expiring. We're pretty late in the game. If there were a congressional action that would renew those, I think plans would probably be scrambling, but I do know that they were required to submit 2 different types of premiums this past summer, one assuming that the enhanced tax credits were available and one assuming that they weren't. I'm not an expert in that world, so I wouldn't opine any further on that. I think if we see the tax credits expire and you do see some of the population on the marketplace, whether that's significant or not, withdraw and not elect to re-enroll or enroll in coverage, then likely you'll see a factor of some more uncompensated care. And I don't know what fills that gap. I do think it's worthwhile to mention that just for clarity, what we're talking about with the expiration of these subsidies are not the original ACA subsidies, but the enhancements that were made in 2020. That did result in thousands of more people in Wyoming enrolling in marketplace coverage. If you go back to pre-2020 era enrollment, you're probably talking about an additional 15 or 20,000 members that elected to enroll in marketplace coverage because of those enhanced subsidies. How much of that is a one-to-one, the rates go up, therefore I withdraw, is as insurance testified to, is hard to predict, but I think we will see some impact there. Long-term economic impacts from that, Representative Yen, I think are just pretty hard to say at this point. See if Deputy Fuchs has anything to add, but I'd leave it there.
Okay, additional questions? Senator Scott.
Madam Chairman, we just had a discussion with the committee on sent forward a bill on bankruptcy for several classes of our hospitals. And we seem to have an extraordinary number of hospitals in financial trouble at this point. My analysis is that the principal cause of that is Medicare has not kept up with inflation in terms of their reimbursement. Something you're going to cover in the rest of your presentation.
Director?
Madam Chairman, Senator Scott, we will touch on that with the potential opportunities under the Rural Health Transformation Program, but your points are well taken. I think it's obviously a mixed bag with hospital finances and the type of payer mix they have in their particular communities. But Medicare is absolutely, especially for your critical access hospitals, a big part of the balance sheet when it comes to revenue. And I think the items that were mentioned earlier today in the discussion with the Hospital Association are absolutely challenges that they face. I will say, Senator Scott, it's a mixed bag of financial health around the state when it comes to hospital viability. Some absolutely on razor's edge with margin, days cash on hand, and some in better positions. Those demographics and the payer mix that is relied on in those particular areas are a huge driver. In addition, what you'll hear as a theme in our rural health transformation discussion here in a few minutes, but I'll tease it right now, is something that won't be foreign to you, certainly, and probably not members of this committee. In Wyoming, with certain types of care, emergency care, EMS, OB, labor and delivery, high acuity behavioral health, the economic challenge is really one of scale related to very high fixed cost and low or unpredictable volume. And we've quantified that very empirically in a few areas like EMS and OB care over the years. And I think those structural elements of the economics of healthcare in Wyoming is something that we're cautiously optimistic we could take a swing at with the Rural Health Transformation Program. But it really is a task in prioritizing those areas because there's a limited time window on these funds. But also as much money as could be coming to the state, I think it warrants prioritization because if it's the entire wish list of investment items, then we really minimize the potential ability to address some of those more structural problems.
Committee additional questions, Director? Senator Hutchings.
Thank you, Madam Chair. Mr. Director, on the Rural Health Transformation Program, have we applied?
Director.
Madam Chairman, thank you. And it might be a nice segue just to dive into rural health transformation now, because that's the first question that I would have answered. No, Senator Hutchings, we have not applied yet. And so a little bit by way of background for this, the Rural Health Transformation Program was a specific section of H.R. 1 that was part of the bill that was passed. Congress appropriated $50 billion into that program for all states. You have to be one of the 50 states. DC and the territories are not eligible to apply for this. And essentially there's two tranches of funding. 25 billion, or half, is basically allocated equitably across states based on a number of factors, how rural you are, et cetera. And that for any state that ultimately has an approved application, there's essentially a floor. So an equitable allocation to states that have an approved application. And that floor is $100 million per year per state. So the way we're looking at it in Wyoming is in that first tranche of funding, if we have an approved application, then we would see over a 5-year funding period a total of $500 million in that first tranche. The second tranche, the second allocation, again, half of the congressional appropriation of $50 billion, so $25 billion. The second half is more competitive. It's what CMS is calling the workload funding. And that's, again, based on the initiatives you're proposing, based on CMS scoring criteria, and a number of other factors, some of which I mentioned this morning with state policy action items like SNAP waivers, presidential fitness test, things that states can elect to move forward with. You have a more competitive part of the application, Senator Hutchings, that we just don't know what our ultimate award would be. To your specific question, we have not applied yet because the application due date is November 5th. It's coming up very quickly, and I think we're in a good place to get ready to submit that application. But before we began working on developing the application, we made the decision along with Governor Gordon to really try to get out to as many communities as we could in a very compressed amount of time. So over the last month, we had in-person public town hall meetings in Wheatland, in Newcastle, Powell, Buffalo, Lander, including Riverton with a specific tribal meeting, Evanston, Saratoga, and Laramie. And we also hosted 3 virtual town hall meetings that had good attendance, and we tried to split individuals out into breakout rooms for the specific feedback. What we did in those public meetings is really try to collect what was important to those communities, what was working well, things that they believe should be scaled, or things that they believe they don't have access to in a reasonable drive time or in a reasonable way. And we tried to use the feedback that we got from those town hall meetings to inform a statewide survey that we put out pretty recently. It was open for about 8 days. We closed it down yesterday. Received, I think, just under 2,000, 1,500 responses. So good participation. But we wanted those public town hall meetings and the priorities we heard to inform that survey, to essentially allow the public, members of your communities, providers, et cetera, to be able to rank some of those priorities. And I wanted to linger there for the committee because both in the town hall meetings that I attended, but also we took audio files from all of them, transcripts from all of them. I was very pleased with the amount of engagement and the feedback that we received. And primarily that you can imagine if we go to communities and say the state of Wyoming is going to receive $500 million, what do you want? That list would get pretty long. Where I think you should be proud, and we should be proud of the public in Wyoming, is that the feedback really did coalesce around prioritization and understanding the need to prioritize more of the systemic issues or not the wish list, but things that are systemic or structural around Wyoming. And I'll mention a few of those because I think it's important. And this was reflected in our survey data, which we're happy to provide to the committee. So kind of ranked in order of volume and voting and importance here. Improving the financial viability of small rural hospitals to provide basic services. That was number 1. Across the board, number 1. And again, I thought it was telling that in the community meetings we had and in the ranking that we saw through the survey, it was pretty bare bones and basic. We'd like a nearby or our nearby hospital to be able to provide emergency care, to have the basics available. Second, as I mentioned before, was expanding affordable health insurance options. Third was recruiting and retaining primary care physicians in order to improve access. Fourth was training and recruiting more nurses and related direct care staff. So kind of 2 categories along just the labor force, the access to the workers. Fifth was strengthening, similar to the hospital viability, strengthening OBGYN and labor and delivery related services. And similarly high on the list was improving or sustaining ambulance availability. So EMS, again, kind of hospital connected in many communities. But again, it was interesting to see we didn't get long wish lists of things and new services and new programs, reimbursement rates. It was really about the basics, a few of which I mentioned today. So we're using those data and the public feedback we got to inform our application. But a couple of things that I'll mention, Madam Chairman, of why this application is difficult. There's obviously federal parameters set by this and things that are not going to be allowable. What's not allowable is just to increase reimbursement rates. So whether you have a service that's paid for or covered by Medicaid, Medicare, private insurance, there's a disallowance on just increasing reimbursement rates. And that makes sense to us because there's a 5-year funding period. If we spent, $100 million or more on just juicing reimbursement rates for 5 years, you get to that now what point in 2031. And I think the federal government, and I think we would prudently agree, we don't want to get into that position. So there's complicated guidance at the federal level on developing sustainability plans for the things that a state chooses to invest in, that we are absolutely trying to follow. The broad federal goals of the Rural Health Transformation Program, there's many articulated. I'll hit a few that are, I think, most prominent in the CMS guidance. Chronic disease prevention, access to care in rural communities, innovative care delivery and payment models, workforce development, and technology are all components that we are trying to pick kind of the cream of the crop of what we've heard, the proposals or ideas that we've received, and the information that with you all over the years through numerous studies, things that we've been able to quantify, really identify where those structural or systemic problems exist. So Madam Chairman, I'll stop there. On the logistical side, we do plan to work with Governor Gordon to submit an application by November 5th. I'm pleased with where we are as a department and as a state in preparing that, and also thankful to community members across Wyoming and you all who helped us get the word out about those meetings and about the survey, and for those of you who attended in person. With that, Madam Chairman, a very broad overview, but happy to answer any questions.
Thank you, Director. Director, can you tell me whether or not the funding can be used towards infrastructure? Speaking to the rural health.
Madam Chairman, yes and no. And I'll take physical infrastructure first in terms of capital construction. There's a general prohibition on new capital construction in these funds. So essentially the building of new facilities or even a full remodel or rebuilding of current facilities is generally not allowed. There are specifics within the guidance and the rules around these applications that capital construction primarily related to right sizing of facilities or facility conversion to more sustainable models can be allowed up to a certain cap within the overall allocation. And a few examples of that would be, primary care clinics converting their space to maybe be eligible to be a federally qualified health center, which has a different, reimbursement model on it. Those types of things might be allowed. Conversions, of physical space that would allow a provider like a hospital to operate what we call swing beds, that again has a different financial model, maybe a more sustainable financial model behind it. That type of construction could be allowed, or double occupancy to single occupancy room conversions if it's specifically tied to a community or a facility or a health system, quote unquote, right sizing their operations based on patient volume or demand. There's a few allowances there, but generally speaking, just taking $500 million and starting to build new facilities within our current service delivery model and current payment structure would not be allowed.
Thank you, Director. And I have one more question, committee. I'm having a flashback from COVID, ARPA funding, big money coming from the feds, right? Talk to me about accountability. When they invest in Wyoming, should we get these funds, does the state or your agency have to prove that outcomes were better or improved, should I say, for the residents of Wyoming, and how the funding was used, what kind of measures are in place?
Madam Chairman, general response, yes, and I'll agree with you. There's a lot of lessons learned from the era of federal funding we received, both from CARES Act to begin and then ARPA going forward, and your Department of Health received ARPA funds directly, and the state, which then was allocated by the legislature, also managed a lot of ARPA funds, and I think we did a lot of good things, but there were lessons learned on how to sustain those types of things. And I think some moments where, when those funds ran out, you had providers or communities, even outside of the healthcare industry, getting to that now what moment. We are really prioritizing avoiding that, and that's also in line with the guidance for these funds. In terms of accountability, yes, there's various clawback provisions within the guidance, and I'll mention that both at the outset and then going forward in each year, there are scoring criteria from CMS, not only on the initiatives that you select, but also the feasibility of completing all of the items that a state proposes in its application, and then an ongoing review of how are you doing on those measures? Is it working? Or if you went outside of those accountability measures, potential clawback provisions of those funds. So we are, again, prioritizing being good stewards if we are fortunate enough to receive an award, but that federal accountability, as you would expect from the federal government, is absolutely there.
And just to follow up to that, what percent, if you were granted the full amount, what percent is allocated for administration or administrative oversight, so to say? So if you have these reports that need to go back, or annual or reviews, ongoing reviews, what does that look like?
Madam Chairman, a couple of answers to that. One thing that I've directed, I know Governor Gordon is on board, but in terms of our application development, we are targeting very low to no administrative cost here as much as possible, recognizing that with some of these things, there will absolutely be some administration that's needed. The application and the guidance from CMS, I believe, caps overall administrative percentages at 10%. We're going to do our best to be well under that. This is not something that we want to result in, even temporarily for the 5-year period, to have a large increase in Department of Health workforce or a large increase in consulting or contracting fees. So along some of the priorities that I mentioned, these are not new problems or challenges facing Wyoming. And in many cases, we have program structures already in existence in the department that could essentially just be scaled with the finances. For example, in workforce development, which is an application, one of the priorities CMS lists, as many of you know, we have operated kind of piecemeal over the years with things like loan repayment programs in our public health division for physicians, nurse practitioners, pharmacists. The legislature over the years has really cut the general funds out of those loan repayment programs. And so primarily now, if we have federal funds through grants available, we will do some loan repayment, maybe 4, 5, or 6 providers in any given year. That's infrastructure that we have that could potentially be scaled for a broader recruiting of personnel, either through scholarships or loan repayment or incentives to practice in Wyoming or be educated into those fields in Wyoming through community colleges around the state. So we have worked with the university over the past 6 weeks with community colleges to look at what would be your capacity in a nursing program or a CNA program, for example. If we were to provide scholarships to folks who want to train to be a CNA or a nurse, how many seats could you absorb or scale up? Again, would be minimally administratively burdensome, but something we're looking at there.
Thank you, Director. And just piggybacking on your comment, would there be mechanisms in place to prevent waste, fraud, and abuse so that students wouldn't be double dipping perhaps on federal monies and then perhaps a scholarship program administered by your agency?
Madam Chairman, yes.
Thank you, Director. Committee, any comments? Senator Scott.
Madam Chairman, I'm going to have a question for the Director to the extent on whether these part of the big beautiful bill is going to solve the financial problems that we're seeing in our hospital community. And I would recall to the committee the discussion we had relating to the bankruptcy bill and the testimony from the Hospital Association on the amount of financial distress that's in the hospital system in Wyoming, and say that, I've been associated with this committee for some 30 plus years now, Madam Chairman, and I've never seen this amount. There's always been some financial distress, usually because we have a bad managed institution or two. I'm seeing this time much more widespread stress than I've ever seen before. And a good deal of it appears to be that, and Director, correct me if I'm wrong, but it looks like a majority of the book of business that the hospitals have is Medicare or controlled by the Medicare reimbursement rate. Because some of that does affect what we can do in Medicaid. The CMS for hospitals forbids any kind of balance billing. So they've got to take what Medicare offers. They don't have any choice. So they're really acting as if they were a utility regulator, but they've not been subject to the precedents that govern utility regulation. So you're starting to have a question, are they taking, particularly with the private hospitals, are they taking property? And the utilities have a very long set of precedents on that. Very difficult in the health area to apply some of those, but we're getting in real trouble because of the federal reimbursement rates haven't kept up with inflation. My question for the director then, as well as he's seeing this kind of distress in the hospitals, but also will these provisions in this federal legislation enable us to cure the problems in good part, or are they outside the scope of what we can do or beyond the scope of what we can do?
Director, is there a cure?
Madam Chairman, not a doctor, so I can't give anybody a cure, but to the good senator's question, I think in part there is some very significant investments we could make to help. Curing the hospital financial problems around the state, I would not guarantee that. But I'll give you a few examples. So one thing we heard resoundingly clear in our public meetings and our provider feedback, et cetera, certain types of hospital services like the emergency department, OB, labor and delivery care, and in certain cases, the EMS system, which can be connected to hospitals, not always. What we think could be very prudent with some of these funds is to really look at transforming, which we're being directed to do, transforming some of the payment models, and in Wyoming, potentially looking at using these funds either temporarily, or we're looking at creative ways to maybe have this in perpetuity beyond the 5-year period to offset those fixed costs. And essentially in a very prioritized way, like OB, labor and delivery, EMS, emergency department, because we know the payer mix is so dependent on, and the hospital's finances is so dependent on volume and those payer mixes. If we could use these funds to, in a concerted effort, but in a thoughtful effort to offset or pay for fixed costs in a different way, in infrastructure that we want and communities want available, then essentially without tweaking or having to get involved in the multi-payer system like Medicare policy or commercial rates, or even in our own Medicaid program, those reimbursements as they exist now for those services, if you have that fixed cost covered or subsidized, now results in a higher cost coverage for those specific services. So that's something we worked, had our deputy spend a whole day with all of the hospital CEOs. It's something that we are working into the application. Ultimately, and let me pause and just mention that EMS is very similar. We know that with rural and frontier EMS agencies, even if those agencies were to bill 100% accurately and 100% for all of the services that they provide, they would still not be able to recoup their costs for a couple of reasons. Certain payers like Medicare do not pay for an EMS visit, even if the visit happens, unless the patient is transported to a hospital. So you have a lot of stabilization that happens in a long-term care facility or at someone's house that ultimately goes unreimbursable. In addition, to have an ambulance available, you're paying for that readiness, you're paying for that fixed cost as an EMS agency. That's upwards of $500,000 a year for an ambulance. You have certain EMS agencies that might have 15, 20, 25 calls in a year. And even if everything was collected and the revenue was generated 100% appropriately, you might collect $10,000, $15,000, $20,000 on a $500,000 expense. Those are things that, again, I think we could get creative and thoughtful in this program and look at reasonable ways to fund or offset the fixed costs in some of those areas, not all, but some of those priority areas we heard about, to then enable the multi-payer system to work better in not only covering those costs, but essentially letting providers or facilities operate more in the black.
Madam Chairman.
Follow up, Senator Scott.
Madam Chairman, I would comment to the committee that it seems to me that the approach the director has just outlined makes a lot of sense to me in terms of trying to deal with the underlying problem that's causing our high costs here. And with these government programs, especially the federal ones, you have to wait and see whether they'll let you do what you think you need to, and do the regulations get in the way of doing things right. You can't guarantee the results. But Madam Chairman, I would like to compliment the director. It seems to me that the department is heading down a sensible route in dealing with these and trying to deal with some of the fixed costs, and gives me some hope that we can resolve some of the financial problems that our hospitals are having. So, Madam Chairman, I hope the committee can keep track of this and follow in the future and be supportive as he tries to make this thing work.
Thank you, Senator Scott. Further comments or questions? Senator Hutchings.
Thank you, Madam Chair. Mr. Director, you've heard me ask this question before, but I'm gonna preface it with a couple comments. When you go out to your website and you click on the Rural Transformation Program, I'm not getting much information or none at all. This page is not found. It would be nice to get more in-depth information on it. And after listening to the previous senator talk about reimbursements are down with Medicare, Medicaid, big question, where's all the money coming from that we're all excited about getting and spending? If we can't pay for these programs, where is this money coming from? Thank you.
Director.
Madam Chairman, Senator Hutchings, it's a good question. And the nuts and bolts of it is it comes from a congressional appropriation. And so I won't speak on a judgment call of, if that's the right thing for our senators and representatives around the country to vote for, but they did do it. And us potentially declining to use or spend these funds would essentially just result in them being allocated to other states. But your point's well taken, because from my perspective, and I believe this is shared with our governor's office and the folks that have been working on this, we do not want to spend these funds for the sake of spending these funds. We want to be thoughtful and prudent with them. And I think the application guidance is one thing, and there's a lot of allowances, but a lot of, unallowed costs for good reason. But as I mentioned before, we do have lessons learned from recent iterations of federal funding packages that came down the pike. But per the Trump administration, Dr. Oz with CMS, the intent behind these funds is really a bit different than what we've seen before. That using these funds to increase reimbursement rates or invest or increase programs that already exist is really not the spirit of these funds. It's really about taking a few big swings or a big bet at transforming structural challenges in specifically rural and frontier healthcare or health service delivery. That's the spirit within which we're developing this application, and why I was hitting so hard on the task of prioritizing. That we do not believe it's prudent to develop a wish list, spend as much money as we can in 5 years, and then call it quits in 2031. But really look at some of those key priority areas where potentially we could address, even if it's temporary, but we're going to try to sustain it beyond the period. Address some of those structural challenges in the economics of delivering healthcare in rural communities, based on the feedback and the priorities that we heard from our community members and your constituents over the past 2 months or so.
Follow-up, Senator Hutchings? Oh,
And Madam
Director.
Chairman, wasn't aware of any dead links. We'll check on that immediately. The website is pretty broad. And again, this has been very, very rapid cycle in that traditionally, you know, grants or funding of this size, you'd be looking at a year or more in terms of the federal development of it. This came very quickly. We didn't see the application guidance any detail until mid-September. With a November 5th application date. So we've tried to do the best we can getting the limited information we have out to the public, but it has been just that. It's been very limited.
Committee, any further questions? Representative Yin?
Madam Chairman, just to follow up on Representative Senator Hutchings' question. So from my understanding within DC, to get enough votes for HR 1, there was sort of a compromise position on folks who didn't want to extend the premium tax credits. So this was kind of a way to placate some of the folks within the majority that weren't willing to vote for HR 1 without something to make up for the loss of the premium tax credits.
Further questions or comments? Representative McCann?
Thank you, Madam Chair. I'll echo Senator Scott's sentiments. You guys have put in a lot of work, so thank you. This might be a little bit too specific this soon. Do you know if there's been any type of relaxation of the accreditation process for Medicare? As far as hospitals getting accredited, it can be very difficult. And then for the ones that are already accredited, sometimes it's hard to maintain just because of the rules that they have. You have to have, like for the smaller hospitals, you have to have 2 patients in the house every single night. I mean, a lot of hospitals don't even come close to meeting that and probably never will. So is there any relaxation of that accreditation process? Do you know that at this point in time? It might be too early.
Director.
Madam Chairman, thank you. Representative McCann, not to my knowledge in terms of specific regulatory or policy relaxations in those worlds when it comes to conditions of participation or certification. Nothing to my knowledge was in HR 1, even outside of this program that was related to that, but happy to follow up and see if that develops over the coming months.
Representative Ottman?
Thank you, Madam Co-Chair, Director, Deputy Director. What I would like to say is, first off, I am so glad that you did travel around to all the counties and then had the website open. A lot of times it seems as though someone's sitting in an office somewhere imagining what the needs are or hears from 2 or 3 people. And while I know that the public was not full bore involved, you did your best, and a lot of us tried to help in that effort. So I appreciate that, and I think you have a broader perspective on the application. So I have 2 questions. One, the way I understand it is the application will be submitted by the executive branch. Is that the Department of the Health, or does the government have the governor have the final stamp on that? And number 2, did you mention meeting with the tribes? I mean, are they going to be part of this? They have their own Indian Health Services, so do they get the opportunity to file their own application, or? Thank you.
Director.
Madam Chairman, Representative Ottman, first, thank you for your comments. I used to fancy myself a smart guy and have all the answers to these complicated problems. This job has disabused me of that notion. So I think the public feedback was very important. To answer your first question, yes, the executive branch and the Department of Health will be the agency responsible for submitting the application. That's something that the application had the governor designate a lead agency to be that application entity. So that has happened. But we have been working hand in hand with Governor Gordon and his staff on not only the development of the application, but also the whole process from the past 2 months of getting out to the public, doing the surveys, those types of initiatives that we undertook. But just in terms of the nuts and bolts, the mechanics of this, he has designated us as the agency to submit. And if memory serves, I'm not sure there's an exception. Most states have done the exact same thing. Governor has designated their health department or Medicaid agency to be the lead. And your second question, please remind me.
Regarding the tribes.
Oh, the tribal
Direct.
meetings. Yes, Madam Chairman, Representative Ottman. We did meet with the tribes specifically, not because there's a different or separate application pathway, but just because it's such an important part of health delivery, you know, the population base, especially in the center of the state, for these types of initiatives, we wanted to get that feedback. And also, you know, tribal members use both tribal or IHS healthcare systems, but also those outside of those systems. So we believed that feedback was important.
Thank you, Director. Any further questions? Okay, seeing none. Thank you for your presentation. That wraps up number 11 on the agenda. We do have one more bill draft. We're going to go ahead and take on the big, okay, we're supposed to have public comment on the update of the big, beautiful bill. Is there anybody that would like to come forward, please? Thank you for keeping me in line, Ms. Johnson. Welcome. If you'd state your name and we'll hear your testimony.
David Foreman. I'm a psychiatrist and I'm the owner of Wyoming TMS. I just wanted to, I'm actually new to Wyoming, but I just wanted to state that to possibly prioritize mental health as in the discussion that was just had. I understand that wasn't on the list of things that was stated, but I think that mental health is something that is important and sometimes kind of people don't want to bring up because of stigma and other reasons. I would say that prioritizing mental health can be very important because it does meet the goals about workforce development, sustainability, innovation. Specifically, it's not always known, but actually untreated mental illness is extremely expensive. So, for example, there was a Columbia study that said that it costs the United States economy about $477 billion a year because of untreated mental health. And treating mental health is actually cost effective. So that you save about $2 to $10 according to a Steinberg Institute. So every dollar that you spend on mental health, you're saving money. And one thing that's not always stated is that, for example, roughly 20% of people that are seen in primary care have an undiagnosed mental illness, meaning that they have untreated depression, they have untreated PTSD, but they don't really want to acknowledge that or don't want to treat that, so they get treated in primary care, and that oftentimes makes long-term problems because you're not treating the underlying issue. They tend to have these chronic illnesses that you don't treat as effectively. So I would say that in terms of the innovation, psychiatry in general tends to be very innovative. I had the fortunate experience back in 2009 where I received a grant from the Office of Rural Health. This was with the VA. And so I was able to do things across the VISN. This is in Wyoming, also Colorado, Utah. I was able to do things with innovative things to try to do educational stuff and treat PTSD. So I'm certainly aware firsthand how effective this can be. But I would just state that if possible for consideration to think about mental health in terms of what is being prioritized. Thank you for your time.
Thank you for your testimony. Committee, questions for the doctor? And can you repeat your last name, please?
Foreman.
Foreman,
Yes,
thank
yes,
you.
ma'am. Yes,
Thank
sorry
you,
for the
Senator
bad
Hutchings.
Dr. Foreman, if you go out to their website where they talk about this Department of Health, the limited information out there on the Rural Health Transformation Program, one of the #1 topics that this program is intended to address is chronic disease prevention and behavioral health, which does include mental health. Just FYI.
Oh, yeah, thank you, ma'am. Yes, sorry, Chairman, thank you, Senator Hutchinson. Yeah, I did notice that. I apologize, I forgot to mention that, but thank you so much for bringing that up. Thank you, ma'am.
Senator Scott.
Madam Chairman, and let me say, I think that this testimony is quite valuable. I think it relates not so much to what we just heard about in the previous presentation, but is going to be quite relevant to what we do in the budget session. in terms of our budget for various items, including mental health. My question is, you spoke about the economic value of mental health and the cost, economic costs it's inducing on us. Do our current mental health programs, are they also particularly valuable in reducing the potential level of violence in the society? Because it strikes me that virtually all the recent examples we've seen of particularly political violence, but also people just shooting things up, there was a big mental illness component to those. Is our existing mental health system effective at treating and preventing that sort of thing? Or are there other things we need to work on there?
Dr. Foreman.
Thank you. Well, that's a really good question. I think that the biggest challenge in mental health, I know this is true for trauma in general, is getting people the help that they need. Meaning that, so I think, and I am not an expert in terms of the individuals per se that have committed violence. I do forensic evaluations, but I haven't done anything on any of those individuals. But it seems that what I observed just by watching the media is these are people that obviously needed help, but didn't get the help that they need. I think that a component that can be done is outreach and education. Oftentimes, because of how mental health is discussed, there's a lot of a stigma around it. I would just say, for a small example, is that for PTSD, it's very difficult to get people to get treatment. I work with a lot of vets. One thing that you can tell people, which is a true statement, is that people are traumatized because they care. In other words, trauma happens because you really care about yourself or someone else, right? And that's just a small example of how you can reframe a conversation so that you can decrease stigma. And so I guess in terms of the answer about violence, I believe that if you can identify systems, like a school system where people are being scapegoated, or other systems, with violence, it's not just a violent act, but then there are things that happen prior to the violence. And it's not possible to predict with certainty who's going to be violent. But certainly, I would say my experience in the military, where I served for 7 years, I know that we were effective in addressing those individuals, and we didn't have any suicides, for example, which is violence to oneself. So I think it is certainly possible to do, but in terms of the general question of if you can prevent that, unfortunately, I'm not qualified to answer that.
Thank you, Mr. Foreman. Any further questions from the committee? Well, I thank you for your testimony, and we have a bill draft coming up that deals with toxicology and death certificates, and probably some discussion on mental health as well. So I invite you to stick around, and if you feel compelled to provide public testimony on that, you're welcome to. So, all right. Any further public comment on the big, beautiful bill and health? Yes. Okay, Mr. Sweeney.
Thank you, Madam Chairman.
Welcome.
I'll be brief, but thank you, Senator Scott, for a lot of good questions. Unfortunately, you had your mic off on a few of them, so I couldn't quite hear. But so my name's Pat Sweeney from Casper, and one of the other things that I've taken up after the legislature, I've joined the board of Healthy Wyoming, and that's Healthy Wyoming. So we have been working for the last several years on access to healthcare and affordability. When the department and the insurance commissioner and folks came up and talked about the enhanced premium tax credits, that's currently what's playing out with the government shutdown in particular. And I just wanted to give a couple of answers. I think Senator Steinmetz asked how many carriers do we currently have, and on ACA, Obamacare, currently there are just two. Blue Cross Blue Shield, which will service the entire state, all 23 counties, and also United Healthcare entered the market, I think, last year, and will again provide, but not in all counties. We lost, we believe, because of insurance cost and provider pay. Mountain Health Co-op, which I'm sure the committee's aware of, but they previously insured 11,000 folks in the marketplace. So why, I'll give you a couple of examples that we have found. So a 45-year-old individual, annual income 62,000, their current yearly healthcare cost is $5,270. The expected cost without the enhanced premium tax credit is $11,180. A 60-year-old couple making $82,000, currently they pay $6,970. It's anticipated that'll go up to $44,392, a difference of $37,422. And a family of four with annual income of about $126,000, their current annual health care costs are $10,710 with the credits. Anticipated that will move to $33,417, an increase of $22,707. So there's more than 40,000 Wyomingites that purchased their health care insurance through the marketplace, including over 9,000 small business owners and self-employed individuals, such as the ranchers that Senator Scott was talking about, that might be some of his constituents. So the current way this is all done, it's based on your last year's income. And then there's adjustments made. And so that is why when you file this year's taxes, I have heard one businessman here in town told me that they ended up last year, or being notified this year, that they owed $78,000. They had a very good real estate year last year when they applied. So there's reason to be concerned, and yes, I do believe it'll mean less folks that will be able to afford their insurance coverage without the tax, the enhanced tax credits, if those do indeed go away. Open enrollment for the ACA opens November 1st, and will close, I believe, the first portion December 31st. Then it will open back up in January again, but you won't have coverage January 1 in that case. And I believe somebody asked that question also. So I just wanted to answer a few questions. We believe the enhanced premium tax credits are very important. I thought Director Johansson did a great job of explaining where he believes the one big beautiful bill probably won't affect us that bad this next year, but a lot of things may change after the way a lot of this is set up. with the one big beautiful bill on the ACA is implementation dates are into late 26, then into 27 and 28. So more to the story. With that, Madam Chairman, I appreciate your indulgence. I know it's been a long 2 days, and I appreciate the efforts of the committee. Thank you, Madam Chairman.
Thank you, Mr. Sweeney. Committee, any questions? Mr. Sweeney? Okay, seeing none. Thank you, sir, for your testimony. Ms. Hunter, is there anybody else online for this? Okay. All right. With that, I will close public comment on agenda item number 11, update on the big beautiful bill and health insurance. Committee, we will stand at recess for 10 minutes. We'll reconvene and we'll work the next bill draft. Thank you. All right, welcome back, committee, from that short break. And members of the public, it's Friday, it's 3:40, and we've got one more bill draft left. So thank you for hanging in there, and thank you for all the input and hard work that the committee is doing here. But we're gonna plug along here. We're going to move on to agenda item number 12, toxicology and death certificates. We do have a bill draft, but it looks like before that bill draft is presented on the agenda, we have the county coroners on the agenda. So if you would like to come on up, we'll go ahead and, I don't know if you'd like to present first or if it would make more sense to run through the bill draft first.
Madam Chair, I would suggest that I could present first if that's okay with you.
Okay, all right.
All right. Madam
Please
Chair,
state your name and
yes,
we'll
ma'am.
hear.
Madam Chair and committee members, my name is Rebecca Reed. I'm the Laramie County Coroner. Thank you for the opportunity to speak today. I'm here to respectfully oppose the proposed legislation that would require coroners to investigate and report the presence of psychiatric medication in all suicides and homicide cases. Violent deaths are complex and may have many contributing factors such as relationship problems, financial issues, substance use disorder, and physical health problems, or other social needs. I would like to raise several concerns from both a professional and a public health standpoint. First, psychiatric medications are among the most prescribed medications. Their presence in toxicology reports do not establish causation. Mandating reporting without proper contents risks misinterpretation of data and may inadvertently stigmatize mental health treatment. This could discourage individuals from seeking help, potentially increasing the risk of untreated mental illness. Second, county coroners' offices across Wyoming vary greatly in resources. Many operate with limited staffing and funding. The Wyoming Coroners Association is working with all offices to standardize training, understand and implement tasks as directed by statute, and maintain standards and rules set by the Board of Coroner Standards. Requiring targeted medication investigation in every suicide or homicide cases would impose a significant administrative burden, potential delay in other critical death investigation, and diverting attention from more pressing forensic matters. Third, this mandate raises serious privacy concerns. Mental health treatment is deeply personal. Public reporting of psychiatric medication use leads to unnecessary speculation and emotional distress of surviving families. I would say that each of you take the moment to think about this. What if this was your loved one and their report was going public record? Wyoming already participates in the National Violent Death Reporting System, NVDRS, which collects comprehensive data on suicides and homicides, including toxicology when available. Strengthening existing systems would be far more effective and less disruptive approach than imposing a new statutory mandate. Coroners are trained to determine the cause and manner of death using established forensic standards. Mandating specific drug investigation is outside the scope of the coroner's role, undermines professional discretion, and risks politicizing the death investigation process. I urge the committee to consider the broader implications of this bill. While understanding the role of medication in violent deaths is important, this legislation carries unintended consequences that could erode public trust, overburden local offices, and stigmatize our mental health. Instead, I encourage legislators to focus on education, voluntary data improvement, additional support for coroner's office to strengthen toxicology capabilities where appropriate. I have provided in those little fancy little binders I gave you Laramie County Annual Overdose and Suicide Fatality Review Reports, 2 verdict and case dockets that are required by Wyoming statute that demonstrates how toxicology levels are available as public record. I've also provided the Wyoming State Suicide Prevention Plan and the Wyoming Violent Death Reporting System reports from 2019 to 2022. These are all examples of how our community and state are currently collecting data, assessing risk factors, and working to prevent violent deaths. Thank you for your time, and I'm happy to stand for any questions.
Thank you. Committee, any questions of Ms. Reed? Okay, seeing none. Ms. Reed, thank you for the binder of information. A lot of information in here. Is there anything that you would like to point out specifically in here, since we're getting this, while we're meeting versus in advance?
Yes, ma'am. Madam Chair, thank you for that. It's my pleasure providing this. I sit on the Mayor's and the Governor's Challenge for Suicide Fatality Review Board team. About 2 years ago, we went to Phoenix, Arizona to learn how we could help prevent suicides. And a group of us went, and it was an amazing adventure, amazing time to learn how we can prevent suicides in the state of Wyoming. Last year, I presented at the Suicide Symposium in Casper and speaking to areas about how we can start suicide fatality review teams in their county along with the overdose fatality review teams. And so right now, it stands, we have 6 counties in the state of Wyoming that are starting these teams, which there's going to be more information available throughout the whole state. So I'm super excited about what coroners are doing across the state to make sure that we're addressing the needs that are out there.
Ms. Reed, and can you tell me how many review teams are implemented statewide?
Excuse me. I'm going to rely on Brittany from Population Health at CRMC.
Welcome. If you'd state your name.
Madam Chairman, members of the committee, my name is Brittany Wardle. I am with Cheyenne Regional Medical Center, and I am the Community Prevention Project Director. To your question about suicide fatality review teams, there are 2 that are currently functional within Wyoming, one here in Laramie County, and also one in Natrona County, with a few other counties going through a process of establishing within this current year. So that includes Sweetwater County and also Park County, I believe.
Thank you. Committee, any questions of Ms. Reed regarding the packet or her testimony? Representative McCann.
Okay, thank you, Madam Chair. You mentioned causation, and I know it's hard to sometimes in these cases establish causation, but in my research of this I think there's a strong association with these medications, with these deaths. I just wonder what your thoughts on that would be.
Ms. Reed.
And by all means, correct me if I'm wrong.
Madam Chair, thank you, and thank you, Representative McCain, for the question. I would tell you that in probably 98% of our suicides here in Laramie County, they have no medication except for prescribed medication, or let me correct that, take that back. In Laramie County, 98% of our cases have alcohol and illegal drugs in their system, okay? If someone is taking their medication like they're supposed to, 10-to-1, they're not gonna die by suicide. Or if they're counteracting with other medication, unfortunately, that's not my job as a coroner to say whether or not they're doing that. But 98% of our cases here in Laramie County, as you will see in our stats, have some kind of illegal drug or alcohol in their system. Does that answer your question?
Do you have a follow-up, Representative McCann? Okay, thank you. Representative Heft.
Madam Chairwoman, my concern is we talk a great deal about suicide prevention. Great, that's good. But and you said 98% of your suicides in Laramie County deal with alcoholism, and what was the other?
Illegal drugs.
Illegal drugs. my question is, wouldn't it be beneficial to have a database in our state that would record legal drugs? We're seeing things like, recently I had no idea about this drug called Kratom that people have suddenly got very interested in, and apparently it's taken a few lives. And I'm concerned about those kind of things. What would be your comment on that?
Ms. Reed.
Madam Chair and Representative Hoff, is that correct? Okay, I apologize, sir. Good points. So when we were at Waco a few weeks back, the association did talk about a database across Wyoming for all corners reporting on that. Unfortunately, can we get all corners to agree and do that? It's very hard with some of your jurisdictions that are smaller that may have a part-time coroner who is also a funeral director. So being able to get everybody on board to create that database, I think is going to be super difficult.
Thank you. Additional questions of Ms. Reed? Okay, seeing none. Thank you, ma'am, for joining us, both of you. Ms. Johnson, if you'd walk us through the bill.
Thank you, Madam Chairman. So this last bill draft is entitled 26 LSO 205, Death Data Collection and Toxicology Transparency Act. And so beginning on page 2, we have definitions of psychiatric drug, toxicology report, violent death, and this act. And then in the newly created Wyoming Statute 74303 on page 3, coroners are required to order toxicology screenings for all violent deaths. The screenings shall include the measurement of therapeutic levels for psychiatric drugs, and the toxicology report shall include the measured blood concentration of any psychiatric drug in the deceased person's system and whether the detected level of the drug is within the therapeutic, subtherapeutic, or toxic range. The coroner's report, coroner's docket, death certificate, and all official records relating to the death shall include the presence of any psychiatric drug in a deceased person's system after a violent death. The written docket and toxicology report shall include a detailed circumstantial narrative, including whether any psychiatric drug or other substances were found in the system of a deceased person involved in a violent death. The staff comment on the top of page 4 indicates that coroners don't generally opine as to the role of a drug in a fatality, except like in the case of a suicide or something like that. The committee may wish to consider taking that language out of the draft. And then Wyoming Statute 74304 on page 5 requires that all violent death data be compiled and transmitted to the Department of Health, the Wyoming Violent Death Reporting System, and the National Violent Death Reporting System. Subsection B in that same section indicates that Wyoming reserves the right to modify its participation in the National Violent Death Reporting System if definitions or protocols interfere with the state's ability to accurately track and report violent deaths, including those involving psychiatric drugs. The staff comment on page 6 indicates that language was originally included within the draft regarding releasing toxicology reports to the public and other persons. This is already covered in Wyoming Statute 74105, and that language I've included in the staff comment if you'd like to read it over. Wyoming Statute 74305, beginning on page 9, allows aggregated data on violent deaths to be used for public health, prevention, and legislative review. And the Department of Health is required to annually compile data on violent deaths and submit reports to the Labor Committee. Wyoming Statute 74306 on page 10 states that Wyoming's definitions and data collection protocols for violent deaths shall be determined solely by state law, public health need, and forensic best practices. The staff comment on page 11 indicates that the CDC provides funding for Wyoming to collect violent death data and report it to the National Violent Death Reporting System. Failure to abide by the CDC's definitions and other requirements may make Wyoming ineligible for those funds. Wyoming Statute 74307 creates a misdemeanor offense for a coroner, medical examiner, or public official who fails to comply with this act. And then the amendment to Wyoming Statute 74105 on page 12 indicates that toxicology reports taken after a violent death may be released to the public under the Wyoming Public Records Act. The amendment to Wyoming Statute 164203 on page 13 is a conforming amendment, and then section 3 on page 13 indicates that this act shall apply to all violent deaths occurring on or after the effective date of the act. And then section 4 provides an immediate effective date, and I would take any questions.
Thank you, Ms. Johnson. Committee, any questions, Ms. Johnson, on the bill draft? Senator Hutchings.
Thank you, Madam Chair. On page 11, you mentioned, it's mentioned in the staff comment, for our information that the CDC provides funding for Wyoming to collect this data. I missed out on part of the presentation, looking for some printed items. So I didn't know if maybe the coroner wants to return. I didn't hear whether we're already doing that.
Madam Chairwoman, Senator Hutchings, we already are sending
Okay.
that information to them. Yes.
Gotcha. Gotcha.
Any further questions of Ms. Johnson? Senator Brennan.
Thank you, Madam Co-Chair. On page 2, line 17 through 19, we have definitions of psychiatric drug. Where were these, and maybe for that, and I apologize since I was not on the committee in the last meeting, where the bill draft is, if this is a bill draft that came from some specific spot that this definition came from, or where did we get this definition?
Ms. Johnson.
Madam Chairwoman, Chairman Brennan, I received this proposed language from Representative Heft, so maybe he has that answer.
Representative Heft, if you have any information you'd like to share or not.
Madam Chairwoman, Senator Brennan, I took much of this information from a bill that was recently passed successfully in Tennessee.
Committee, Senator Steinmetz.
Thank you, Madam Chairman. Just with the staff comment, so we are collecting this information. Where's it going? Do we have access to it? Through the CDC provides, so who's collecting it if it's not the coroner, number one? And then where's it going, and do we have access to it to address some of the good representatives' concerns in this bill?
Ms. Johnson.
Madam Chairwoman, Senator Steinmetz, so this information goes to the Department of Health. It also goes to the CDC. And I believe that both agencies report on that data in generalized terms. Does that answer your question?
Further questions of Ms. Johnson? Senator Hutchings.
Thank you, Madam Chair. So, we have our good representative requesting this information. Who else is requesting this information? How valuable will it be to anyone out there except for you? Not to slam you, but just, hey, this is a lot of information to gather for your benefit. And then why is a coroner involved in this if the hospitals or the Department of Health is already doing this, gathering this information? I'm sure there's a place where we can go out and look at it so we don't have to reinvent the wheel, if that makes sense.
Ms. Johnson, if you.
Madam Chairwoman, Senator Hutchings, I believe how this works, and Coroner Reed can correct me if I'm wrong, but I believe the coroners report this type of data to the Department of Health, who collects it, makes a report on it. And I could be wrong, but I'm almost positive that's the way it works.
Okay, further questions on the bill draft for LSO? Representative Wasserberg.
Madam Chair, this is
Representative Thayer, hang on one second. I'm gonna address, I'm gonna let Representative Wasserberg ask his question.
Thank you, Madam Chair. Yeah, just out of curiosity, is this information available to the public too, or just the CDC?
Again, Madam Chairwoman, Representative Wasserberger, I believe that these reports are available to the public. Like I said, they report in generalized terms, nothing identifiable or anything like that. So I believe that these reports are accessible. And if somebody wants to correct me, I would be open to that as well. But I believe that's the case.
Thank you, Representative Wasserberger. In the binder that we were provided, there is a sample of the violent deaths in Wyoming report. Whether or not it goes into psychiatric legally prescribed medications, I don't know, as we're just getting this. There is a toxicology page, it looks like on page 21 of that report, and it's, let's see, it's the fifth tab in, or sixth tab in. Additional questions of Ms. Johnson? Go ahead, Representative Wasserberger.
Thank you, Madam Chair. When you say generalized, does that mean that it's just, you know, some of it's under pharmaceutical, some of it's under alcohol, some of it's just illegal drugs, like very, I guess when we say generalized, is it just, you know, very broad categories, or do we have the specifics of Prozac, alcohol, what else could there be?
Ms. Johnson,
Yeah,
if-
between.
If you can answer that.
Madam Chairwoman, Representative Wasserberger, I don't think these reports go into psychiatric drugs. I'm not entirely sure how descriptive they are. Maybe somebody in the audience could better answer your question. So,
Any further questions of Ms. Johnson on the bill draft? I'm sorry, Representative Thayer, you were waiting. I apologize.
Thank you, Madam Chair. Question to either Ms. Johnson or Coroner Reed. HIPAA, does not HIPAA apply also in death? Would be my first question. And second, if that is a true statement, then wouldn't this bill be unconstitutional? And then my third would be, is it generalized? Is the report from CDC and Department of Health generalized because of HIPAA and they cannot use names? Thank you.
Sorry. Ms. Johnson. And again, committee, right now we're at the stage where we're talking about the content of the bill draft for LSO. We can ask more questions of our expert witnesses that are perhaps in the audience when we move on to public comment, as we might have folks that testify or don't. Ms. Johnson, regarding HIPAA and the law, if you know, as it pertains to deaths.
Madam Chairwoman, Representative Thayer, as to that particular question, I would refer to Coroner Reed on that. I think she'd have a better answer than I would.
Thank you, Ms. Johnson. Coroner Reed, we'll take this one question and then we're going to continue on the path with the bill content.
Yes, ma'am. Madam Chairman, so it is in a violation of HIPAA law, just like it would be in a hospital. So no records in the state of Wyoming for coroners are public record, except for the public record docket that you have a copy of, which is listing the cause and manner, any relevant toxicology related, the deceased name. And I did, for family's sake, I did not know if anybody was related to the two that I pulled, so I did black the names out.
So confirming, Ms. Reed, you can redact information, but provide.
I'm sorry, can you repeat that?
You can redact personal information from a report, but provide statistical information.
That is correct, yes, ma'am.
Thank you. Okay.
Madam Chair,
Senator Crum.
and I know I'm slowing things down, so I'll try to be quick here. Just question on page 11, and then starting on line 15 through 21. Just the penalty area, is that typical, and is that even legal that we fine public employees for just a question, I don't know.
Ms. Johnson.
Madam Chairwoman, Senator Crum, I believe that the new 74307 is fairly unique in Wyoming statute. I can't think of any other examples where we necessarily penalize public officials in this way, except for like in situations of like bribery and things like that. It is rather unique.
Thank you, Madam Chairman. So just for my clarification, Madam Chairman, unless it's fraud, bribery, some theft, something like that, this would be very unique, to our statutes.
Ms. Johnson.
Madam Chairwoman, Senator Crum, yes, that is correct.
Thank you. Thank you.
Okay, committee. Additional questions on the bill draft for Ms. Johnson, LSL. Senator Scott.
Madam Chairman, looking in the bill title, lines 6 and 7 and 8, it says indicating that state law supersedes federal and international requirements. It's the federal requirements that raise my question. They appear to relate to page 10, lines 18 through 23, and page 5, lines 23 and following. And my question is, are we doing things that we're constitutionally allowed to do, or are we violating the federal supremacy clause in the federal constitution with this one?
Ms. Johnson.
Madam Chairwoman, Senator Scott, when I was looking at these particular provisions in the bill draft regarding page 10 and page 5, so from what I understand, a lot of the reporting for violent deaths is voluntary, but if you don't do it the CDC's way, the state won't be provided funding to collect that kind of data. As far as like other federal laws, I didn't really dig up anything where we would necessarily be violating federal law. But if we don't abide by the terms of what the CDC is asking for as far as violent deaths and data and things like that, we just wouldn't be receiving, we would be risking losing federal funding for that.
So,
Follow up, Senator Scott.
Madam Chairman, so it's the risk, there's a risk here, but is of losing federal funds, not violating the supremacy clause. Okay.
As far as, Madam Chairwoman, Senator Scott, as far as I could tell during my research, that's all I found. Yes.
Thank you. Additional questions of Ms. Johnson. Senator Steinmetz.
Thank you, Madam Chairman. And I'm not sure it's a question for Ms. Johnson, but the good bringer of the bill and then for our committee. So if you go into this handy little book on page 20 and 21, it tells you all of it says method of death, and it goes through all of the things that could happen, how people died. And then if you go to page 21, it tells you the toxicology of alcohol, amphetamines, antidepressants. I mean, I just am wondering and trying to ascertain what additional information we want with this bill from what's already being collected, and how we would be able to do that. So either one of them could answer, but I just wanted to direct our attention to this. I wish we would have had it sooner. We try to get something of this volume. It's very difficult to read when we're sitting up here. And so just encouragement in the future to try to get those materials in a little sooner so that we can give them the due consideration that they warrant. But I was glad to turn to this page and I'm just wondering what else you want or need, or what this bill is trying to do.
Senator Steinmetz, thank you. And you're referring to the method of death, suicide, correct?
And the toxicology is on page 21.
Right, but the method of death is suicide in particular. That's provided in
Suicide
here.
by sex. And so, but I'm not sure, Madam Chairman, how a coroner can provide, if the death is a homicide, we can't think that the person who perpetrated the crime is going to be dead, and how would the coroner be able to test the the perpetrator? I mean, and the person who's dead it was a homicide, so how did the drug affect the homicide, and how do you find out? I mean, what are we after? I'm very confused by this bill.
Thank you. Representative Heft, if you'd like to
Madam
respond.
Chairwoman, Senator Steinmetz, the intention of this bill was to track psychotropic drug use and deaths involved in the use of those drugs, specifically murder-suicide. This was brought about by an incident that happened in Bighorn County in February while we were in session. And it piqued my interest in that we've seen a greater level of use in these psychotropic drugs and these outcomes. And so my intention was specifically a Wyoming database, not so much a CDC database, but something we could track ourselves and get a handle on how these drugs are being used and at what level. I recognize that not every suicide, and you bring up a great point, the murderer cannot be checked, unwillingly. And so I understand your concern.
Thank you, Representative Heft. Okay, Ms. Johnson.
Madam Chairwoman, Representative Heft, just for your information, and Coroner Reed can correct me, but I'm pretty sure that if you're looking for ketamine, I don't think that's classified as a psychiatric drug. I think it's classified as, they usually use it for like anesthesia and things like that. So if that's what you're looking for in particular, you might want to consider an amendment as well.
Thank you, Ms. Johnson, for pointing that out. Okay. Representative Yin, question for Ms. Johnson,
Correct.
LSO.
Yes, Madam Chairman, Ms. Johnson. So on page 11, knowing that this came from another state that probably doesn't have the same coroner system as us, it has the penalty for a medical examiner. Do we have medical examiners in our state statute and also our medical investigation system?
Madam Chairwoman, Representative Yin, once in a while, when a death is particularly complex, they will send a body to a medical examiner for autopsy. So my understanding is we don't have a whole lot of them within Wyoming. We tend to send them out of state, but we do use medical examiners. once in a while.
Thank you, Ms. Johnson. Okay, committee, we will move on. Are there any government agencies that would like to come forward to testify on Death Data Collection and Toxicology Transparency Act? Okay. No government agencies. We'll open it up for public comment. And there's none online, right? Government agencies, but government agencies. Okay. All right, public comment in the room. If you plan on testifying, we've got 3 seats up here or 4 seats up here, so please come occupy them. Come on up. Don't be shy if you plan on testifying. All right, whoever would like to begin, please introduce yourself and we'll hear your testimony.
Madam Chairman, Joey Carenti, and I think the only bona fides I have in this debate is I'm a failed applicant as a death investigator in Carbon County. They went with someone else. But as I look at the bill and knowing I've worked with my county coroner, I'm wondering if any of these additional administrative and potentially forensic burdens, things that the coroner's office would have to do, has been contemplated against the recent 25% reduction in property taxes, and counties now stating that they have to reduce services, and now we're putting an additional burden on one of our elected offices in every county that serves a pretty vital and 24-hour-a-day purpose. Also, the expectation that they write a detailed and circumstantial narrative, including all these things that not only because of HIPAA they may not have access to, but because of HIPAA, the people they'd have to get that from may not give them access to. So we may be asking for something in statute that they couldn't complete 2 times over. Additionally, to Representative Yin's point of, do we have the medical examiners? I know we have some in Wyoming. Carbon County, if we need a medical examiner or an official forensic autopsy, we tend to send down to Fort Collins. So my question is, if this procedure has failed to be adhered to by a medical examiner down in Fort Collins, how is that enforced? Or is every time this procedure failed to be recognized and utilized properly, is it always going to be the coroner who's going to incur that criminal penalty? Because it ultimately is their responsibility to sign off, certify, and distribute those documents where they go. The existence of a criminal penalty, not just because it's an elected official, but especially a coroner, bothers me, again, going back to an additional burden to the office in the county. If you put a coroner in jail for 6 months, you are now reducing the staff. And even if that coroner is going to come back in 6 months, you have 6 months where you have the potential for more violations of this proposed statute because you have fewer people doing the same job. So even if the county commissioners appoint an interim coroner to cover the elected position that's vacant during that prison sentence, you have to either hire temporary staff and then after 6 months say thanks, or find a way to legally remove your coroner because you replaced them, and this violation of law is not an automatic disqualification from service in that office. So I think we have a lot of problems in the structure of this bill with enforcement and then effect that hasn't been properly contemplated for Wyoming's purposes. And if I'm reading it correctly and hearing everything correctly, this information is mostly out there, maybe not as complete as we want, but can be gleaned from records that are already in the possession of the Department of Health. But then that brings me to the question of, what are we comparing those records to? Everybody who's died in this violent manner with this toxicology, or everybody who takes this thing we found in the toxicology who maybe have never committed or been involved in a violent crime? What are we looking not only to get, but compare it to? So those are just some of my concerns that maybe the committee can contemplate. And with that, Madam Chair, I will stand for any questions.
Thank you. Committee, any questions of Mr. Corianti? Okay, seeing none. Thank you, sir, for testifying, for joining us. Ma'am, please state your name. We'll hear your testimony.
Good afternoon. Good afternoon, Madam Chairman. My name is Jan Cartwright. I have testified before this committee a number of times on health issues, but I'm speaking today personally on behalf of my family. I've timed myself at 3 minutes, so I hope you'll allow me the extra time. I know this is late. What is missing in this discussion is the personal impact on families that a law like this would have. One of my family members attempted their own life 10 years ago. Fortunately, they survived. What came before and after is my family's own story of struggle, questioning, guilt, and the inability to find a happy ending. Mental health is not a linear illness. It is caused by a virus like chickenpox. In that scenario, the parent of a child who gets sick only has to figure out how to get the child well. The cause is the virus, not some family or system problem. It is not so easy for family members of people who have significant mental health issues. The cause is as much in question as the treatment. That search for cause and effect leads to countless hours of internal strife and self-doubt for those closest to the person experiencing the illness. Even then, the way to help the person become well is about whether they're willing to take medication or self-medicate with alcohol or illegal drugs. My family member began taking prescribed medicine after the suicide attempt, and I watched them become the person they had been before the grip of illness. So my experience is exactly opposite of what this bill is construing. This is not the first time that I've seen legislation based on one tragic event. I will point out that the tragedy earlier this year in Wyoming that's mentioned as a reason for this bill is ongoing because the family is seeking answers in court. This, in my opinion, is where the answers will be found. I believe that the shame of the public square on family members is more than enough when a violent death occurs. Families shouldn't have to then answer to non-experts who come riding over the hill to point fingers at fraught and tragic events. Please do not rob my family of our privacy dealing with the illness of one member by passing a bill like this, which totally ignores all of the work done at the federal level, both through rigid studies and scientific review. My life experience has fueled much of my career, so now changing to my advocate hat, I would say this. If lawmakers are really interested in preventing suicide, then why not make Medicaid available to more people for more mental health care? or put into place any number of additional steps to help people within our borders thrive. Thank you, Madam Chairman.
Thank you, Ms. Cartwright. Committee, any questions? Okay, Representative Heft.
Madam Chairwoman, I'm just going to ask this question. You don't believe it would be beneficial. I'm not seeking to injure a family. I'm seeking to gather data on these psychotropic drugs and their use. It's an appearance to me that there's increasing use year after year, and it doesn't take too long to look at any kind of information that comes in magazines, television, everywhere, that many of these drugs, there are so many side effects. Shouldn't we be keeping track of them and what happens in these tragic situations? I believe we can do that without injuring families.
Madam Chairman.
Ms. Cartwright.
Representative Heft, absolutely understand your concern. However, I would argue that, so I used to work for the American Heart Association, and it's a volunteer organization that thrives on donations. And I would work with people in Wyoming who would say, well, I want my donations to stay in Wyoming. And to that, I would say, we're not going to cure heart disease in Wyoming. We don't even have a medical school here. So I would argue that this idea that somehow psychotropic drugs are not peer-reviewed and tested and gone through a rigorous review is totally ignoring that fact and deciding that in the state of Wyoming now we have a better idea of what this should be. I agree. I don't think that drugs should be advertised on television. I don't think somebody should go to the doctor and say, I want that purple pill, whether I have the illness it's going to cure or not. But I do think that there are national efforts to keep people safe. Mental illness is a terrible thing. It robbed me of my family member. I pray every night that they'll come back to me. They're homeless. They live in another state. It's not a happy ending at all. So I would argue that I think that the legislature should keep an eye on these things, but I don't think that figuring out this level of involvement of drugs is going to fix anything, in my opinion. I'm sorry for the family where that happened. I'm sorry for my family. We struggle every day. Thank you, Madam Chairman.
Thank you. Any additional questions of Ms. Cartwright? Okay, seeing none. Is the Department of Health still in the room? If you'd come forward, please. Thank you, ma'am, for your testimony. Okay, we'll continue on with public comment. Ma'am, if you'd like to go. If you'd introduce yourself and.
Hi, I'm Jamie Turner. I am a mother who lost her son to suicide 2.5 years ago. There were many contributing factors. He was bullied in school. We tried many different things. He was depressed. He had anxiety. We sought out therapy for him, medication as well. He was on a good path. And ultimately, a few days after his birthday, he did die by suicide. I don't think that this bill is a positive because it is more intrusive than what is currently out there being reported by the coroner. And I think it being offered to the public, whether it is names are retracted, anything like that, it still reopens wounds. And a bill in, what was it, Louisiana, I don't think represents Wyoming or what Wyoming is. Wyoming is very, I can't think of the word, standoffish, I guess you could say, of seeking mental health help. And in having this reported, I think it's going to be very even more standoffish for them to go and seek mental health help, in my opinion. And it was hard enough for us to get my son the help that he needed, and ultimately we still lost him. And that's just a mother's point of view on it.
Ms. Turner, thank you for sharing your story,
Thank you.
your personal story. We sympathize with you, and thank you for being here this evening and sharing that. Okay, I'm going to move to Department of Health next. And remind me how to pronounce your last name. I struggle with it. Sir.
Madam Chairman, Franz Fuchs, Deputy Director
Fuchs.
of the Wyoming Department of Health. That's correct.
Thank you. Okay, Mr. Fuchs, so it's my understanding that there's a question out there in the media nationally that's posed that really are the Secretary of HHS is trying to tackle, and that is whether or not antidepressants cause mass shootings because of a lot of heightened awareness surrounding the situations that have occurred in many states. So the question is elevated. And then it's also my understanding too that HHS has also posed or taken on the task to try to study the issue, whether or not there is a correlation. My question to you is whether or not Department of Health is following the potential studies that are going on by the Department of Health and Human Services, and if perhaps you have anything to share or to enlighten the community on that topic at this time.
Madam Chairman, again, Franz Fuchs, Deputy Director of the Department of Health, joined here by Kendra Herrera, who is our Deputy State Registrar. She runs the Vital Statistics Services. We're happy to try to answer any questions on this bill. To your specific question, no, we have not been intimately tracking that particular issue. We have, particularly last month, a lot on our plate, as you might imagine, and we are stretched pretty thin. We do track, for example, we have that violent death reporting system. We have shared some reports with the committee on how things look in Wyoming in particular. We're happy to continue that reporting with this committee. Just pick up the phone. We're happy to try to share those reports. Aside from that, I'm just happy to answer any questions you have on this bill itself. I'm not a legal expert as far as HIPAA goes. My understanding is that the coroner reports they're not a covered entity, so HIPAA may be more tangential. But again, you should probably rely on your legal counsel for those kind of questions in particular. But if you do have any specific questions to how VSS tabulates or collects this kind of data, how it interacts with the violent death reporting system, we're happy to try to take those questions.
Thank you. So committee, if you have any questions about the data collection, now would be your time. Department of Health, Representative Yen.
Madam Chairman, thank you. So this Department of Health Violent Deaths Report, I think it's really useful. It just sounds like there might be an extra table that we kind of want in here, or that the representative who brought the bill wants, which is, murder and suicide. If they also committed suicide after murdering people, could we track those things? I don't know if we have enough of that data to aggregate it without releasing personal information of the people who committed those atrocities, but if we did, would we be able to report it in this? It sounds like we already have a database, the violent death reporting system, so we have that homegrown part. But we have that one part that it sounds like that's the intent. Could we do that without this bill?
Mr. Fuchs.
Chairman, Representative Yin, that's a good question. I think, when you talk about aggregated statistics, right, we are a very small state. The number of murder suicides that happen any given time is very low. And so to say you can provide aggregated data when it's an N of 1 or N of 2, it's very easy to tie those to news reports, to other sources of data. So it becomes very sensitive and very difficult to kind of make those judgment calls. That said, I mean, to the extent we can, to the extent we think we can release de-identified data, we're happy to try to work with that in the reporting. I just would, the other day, caution, not only is it very difficult to draw causal connections, right, but even estimating the correlation is difficult when the sample size or even the population size here in Wyoming is so low. National data is probably far better suited just because there's so many more in any kind of statistical effort, right? You're going to want a decent sample size to estimate even a correlation in a rigorous way. So Wyoming data, I would say, is less useful from that scientific purpose.
Follow up, Representative Yin.
Yeah, thank you, Madam Chairman. So, Mr. Fuchs, appreciate it. So if we pass this bill, you're basically saying that if we only had an N of 1 or N of 2 of murder suicides in the state every year, then if we forced reporting of it, you'd basically be able to know who it is, what they were on. We wouldn't be able to anonymize it, essentially.
Mr. Chairman, Representative Yin, and I think that was when I was looking at the bill, there's talking about the public records, right? The page 12. When it talks about records released under the subsection shall have all personal information redacted, right? And that makes sense. But it's hard when you only have an N of 1. There's an identifiability issue even with redaction, right? Because you can still tie to other sources of information to connect that case.
Thank you. I have one question. So the good representative, Representative Heft, mentioned a tragic situation that happened in our county, well, in nearby county, which was reported all over the news, tragically as well, with personal information regarding the family. And then later it was further reported the type of prescribed drugs that the individual, the decedent, was prescribed. How does that information get out there? If we have HIPAA and low populations like Representative Yin alluded to, how does that happen?
So, Madam Chairman, my understanding is that may have come from the coroner, and it certainly didn't come from us. Once the information, there's various statutes that govern the confidentiality of the reporting from the Department of Health and vital statistics in particular. But my understanding is that, and you probably have some experts here that could talk to the coroner statutes more intelligently than I can. I'm happy to defer to Ms. Herrera here if you have any questions about vital statistics. But we, once it sort of enters a covered entity, if that information enters a covered entity like the Department of Health, and VSS is kind of carved out of that partially. But if it went into public health, say, for example, and public health was part of that covered entity, then HIPAA does apply, and we have restrictions on that. My understanding in the case you reference is it came from the coroner's office, but again, that's just from me reading the newspaper. I don't know exactly where it came from.
Thank you, sir. Any further questions of the department? Okay, seeing none. Thank you, and I appreciate your willingness to come up on the fly. Thank you for joining us. Sir, if you'd state your name and we'll hear your testimony.
Thank you. My name is David Foreman. I'm a psychiatrist. I want to say that I want to speak against the bill. At the same time, I wanted to say that I certainly appreciate Representatives Heft's efforts to try to understand what happened. I think that when tragedies happen, like what happened, we all want to try to understand. We want to help, and I think that although things can be done on a federal level, I think that more eyes on is beneficial. My main concern is I've had the experience professionally where information can be used or data can be used in a way that it wasn't intended. So I think the intent is to certainly help. But for example, I was in the military, and for a while what they did when I was deployed is they would track the number of people with suicidal ideation, SI. And so what happened, we had a report every week to kind of the command. And so we did a lot of outreach during this time frame, and so that the actual number of people that expressed that they were suicidal went up because of the outreach that we were doing. So the number looked bad because these numbers went up, but actually, if you went over the whole end of all the people that were suicidal, including all the people that we didn't know, was suicidal because they didn't report it, we actually were doing well, and we had no suicides, and I was able to explain it, and that was not a problem. But I would just contend that my concern is that given the high degree of emotionality associated with these issues, and a lot of maybe potential bias regarding that, is that if this bill is passed, then it could lead to a potential unintentional adverse effect. And I think it was stated previously, I'm not aware from my perspective how this would add additional information that isn't otherwise available. Thank you for your time.
Thank you, Dr. Foreman. Senator Brennan.
Thank you, Madam Co-Chairman, and thank you for being here today. So first of all, just because I get them mixed up, but I've got it straight today, I'm sure. You are a psychiatrist and therefore licensed to prescribe medications, including things that we would consider psychotropic drugs. And my first question is going to be, we were told that there's maybe this thought that there's a greater role or there's a greater number of abuse in psychotropic drugs these days. Medications that are actually being prescribed by providers, is there any research out there to indicate that there is a higher amount of abuse of these drugs, one, and two, how many of them? I mean, I'm not going to go into all the different kinds of classes of medications that we could go into, or even how that they work on the brain, but let's see. I lost my train of thought. But anyways, so is there research out there that would suggest that when these medications are being prescribed? Oh, so then my second one is, how often are these actually, is there potential for abuse in these psychotropic drugs? I mean, we think often of some of your opioids and stuff like that that are on, those are hot topics right now. But what about some of your, let's say SSRIs, SNRIs, those types of things?
Dr. Foreman.
Thank you. Thank you, Senator. So to answer your first question, hopefully, generally as a rule of thumb, there's a direct connection between abuse potential and the half-life, or how long a medication kind of stays in your body and how quickly it reacts. So most things that people abuse, like methamphetamine, alcohol, these are things that you take the substance and then you experience an effect pretty quickly. The thing about medications that they use to treat depression, actually the way they work is that they get in the body and then they actually take a couple of weeks to get the effect, meaning that it has to go into your brain, you have to make new RNA, new DNA, new RNA, and then so you basically take several weeks to get the effect. I'm not aware of any studies per se of at what level these are abused. I would just say that clinically, I used to work in jail, for example. And so things that were abused were things that had more of an immediate effect. Things like, Wellbutrin is an antidepressant, which people would cut up and snort. And so they would, to get high. Seroquel is a medication used to treat, it's a mood stabilizer, but that has kind of more of an immediate effect. It's not the effect of the medication long-term, but it does kind of make you feel more sedated, maybe more like something like cannabis. And so people would abuse that. Outside of kind of like correctional facilities, I can say as a rule of thumb, I've been I guess I've done psychiatry about 30 years. I don't usually think about when I prescribe medications that people are going to abuse them, say for recreational abuse. What does happen is that some people feel like the medication isn't working, and so of their own accord, they will increase the dose. I wouldn't necessarily call that abuse, but they will say, I'm taking 20 of this, maybe 40 is better, right? So they will, change it on their own in order to try to get more help. But I would say in terms of abusing a medication, like I think of abuse of a substance that I use it in order to get high, or like maybe you can abuse, say, benzodiazepines in order to like get a high or something like that. The medications like that for depression, generally, they're not abused because they don't cause sort of relatively immediate a positive effect. To answer, I guess, make sure I understand correctly, the second question, I guess, was a different class of medications, and hopefully I understood that correctly.
You've answered my questions. Thank
Okay,
you.
thank you, ma'am. Sorry, thank you, Senator.
All right, any, Representative Wasserberger.
Thank you. Excuse me. Thank you, Madam Chair. And this is probably a question for you, Coroner Reed. So I've gotten the opportunity to hear some of the concerns from testimony from a privacy standpoint. Would there be opportunity to maybe not immediately report the incident, but maybe at the end of a term that can be turned in for a database that way, so it's a few years past the incident occurring, so there's to help protect people's privacy?
Ms. Reed?
Madam Chair and Representative Wassenberger, thank you for the question. Yes, and that's something that we spoke about at the Suicide Symposium last year in Casper. The very small jurisdictions, their concern was people on the board doing the reviews are going to know this person, right? So I said, let's go out several years until you review those cases. So that is a concern, and yes, you can do that. Right now here in Laramie County, what we're doing is we did 22, 23, and 24. We're inputting all of our information into the state REDCap system for 2025, but we will not review those cases till 2026, if that answers your question.
I appreciate that. Thank you.
You're welcome.
Committee, any additional questions of Dr. Farmer or Ms. Reed while they're both up here? Representative Guggemos.
Thank you, Madam Co-Chair. My question is for the doctor. Are there any studies, tests on polypharmacy? I mean, we have all these different drugs, and it seems that patients are being given multiple prescriptions for these things. Is there any data on how these medications interact with each other? And could that be a causality of people acting completely different? I mean, because the reports on some people are, we never thought these people, they were the nicest person you could ever meet, and then they do something absolutely horrendous. So is there any kind of polypharmaceutical studies on how they interact with each other, and could this be a causality?
Dr. Farmer.
Thank you. Thank you, Representative. Yes, well, the short answer is there's not a lot of studies done on polypharmacy, but I would say that you can get, when you do discuss polypharmacy, a common fear or concern of polypharmacy is that you can't get a paradoxical effect. Paradoxical effect meaning that you take something like Ambien, which is supposed to make you fall asleep, but it keeps you awake, or it makes you act differently than normal. And so certainly it is possible that when you are involved with polypharmacy, sort of the rule of thumb is once you take more than 3 different medications, it's hard to predict what's going to happen. And the other clinical reality, I can say if I've done this for a long time, I mean, there's different reasons for it, is that many individuals are on polypharmacy, which potentially could be a significant problem. In terms of causality, I think was mentioned that at best, you can probably determine association. Causality is very difficult to determine. But in terms of, theoretically, yes, it's certainly possible that if one is using polypharmacy or if one is using alcohol or other things like cannabis, there's a lot of interactions between, say, cannabis and medications or alcohol and medications. And so it is certainly possible that someone could ingest something and ingest something else and act in a way that is maybe, say, unexpected. But unfortunately, in terms of how most drugs are tested for the purposes of keeping the outcome simple, is that polypharmacy isn't really, except for a few examples of, say, augmenting medications, it's not studied scientifically very often. I hope that answers your question.
Thank you, Doctor. Representative McCann.
Thank you, Madam Chair. This is more of a comment, but I invite you to, remark on it. I just pulled up just a quick little search, antidepressants versus suicide ideation. And, and these are black box warnings that come from the farm companies themselves.
Yes. Sir.
So yes, they've done some research on it, but how far they've taken it, I don't know. But since 2004, all antidepressants carry a black box warning for increased risk of suicidal thoughts and behaviors in children, adolescents, and young adults under 25. Risk is highest during the first few weeks of treatment or dose changes. Examples, SSRIs, SNRIs, TCAs, which is amitriptyline type stuff. Again, just a comment, it just hasn't been brought up yet that these are the medicines we're talking about following. And I always have a suspect of any study. You got to look at who paid for it. So anyway, just a comment.
Dr. Farmer, if you'd like to comment. If not.
No, sorry, Representative. I concur. I mean, I think that's a really good point. There is a black box warning. I didn't mention that, but there's a black box warning, meaning that anybody who's under 24, when you give anything like SSRI, you should be monitoring them closely. That's something that's kind of well known in the psychiatric committee. Oftentimes you will see them back within a week, and you want to monitor these individuals for increased suicidality. That is a concern. There's been a lot of debate. I guess there's some controversy regarding that in terms of, is it actual just suicidal ideation, means thoughts about suicide, versus actual suicide attempts. But the bottom line is that whenever you're changing anything with someone who's not doing well and is suicidal, you want to monitor them closely. I would say that, I don't know that, I mean, so I do concur that it's a problem. Also, there is a problem that the people that are doing this research are pharmaceutical companies oftentimes. And, the adage you may know is that, statistics don't lie, people do. So it's really, you have to, I mean, as a psychiatrist, I have to be very cognizant of that. And when I read these reports and to try to critically evaluate them for their conclusions. So
Thank you. Okay. Did you, Ms. Reed, have any final comments?
Yes, ma'am, Madam Chair, I do. I wanted to clarify a few things. With Representative Wassenberger, you talked about the data, the NVDRS. If you go to cdc.gov/NVDRS, that report is public record to anybody that wants to look at it. Okay. Also, in regards to Representative Yen, in regards to medical examiners, we do not have medical examiners in the state of Wyoming. They're called board certified forensic pathologists. And those are the same that are in Colorado that most of us use. The one in Fremont County, we have one that comes down to Bighorn County, and there's other jurisdictions that go to different, say, Boise, Idaho, or other locations, and they all use board certified forensic pathologists. So, and that's also in our corner statute at 74101. So I wanted to clarify that. Also wanted to clarify to let you guys know how the state is getting this information to put in the NDVRD, or the, that's a lot of words, I'm sorry, and it's been a long day. I'm living off 2 hours of sleep right now. So anyway, so how this works is a violent death reporting system will send over requests because they have access to vital records. So they can see when someone dies by suicide, homicide, car crash, overdose, and all of those. So what they'll do is they'll send those requests to each individual offices, and then those coroners will send those reports back over to the gentleman that does all this reporting. Of course, he is a little far behind. He's only one guy, and I totally understand that. But though that's how that process works. So they're directly getting all of that information from each coroner that is participating in that. Now, the statute says we are to participate in that. Whether or not all corners are doing that, I can't speak for that at this time. So that's how that works. Does anybody have any questions on that one?
Thank you, Ms. Reed. Further final comments?
I just want to say thank you very much for taking the time to consider this. I don't want to disagree with Representative, and I can't remember how to pronounce his name, so I apologize. So I don't feel us as coroners, you say, you know, talk about the side effects and keeping track of drugs. I don't think we as coroner, that's our job, and I don't feel that we should be doing that. I think we should be looking into the CDC and maybe your primary care physicians or your pharmaceutical people who are prescribing these types of medication. Maybe that's the data that they could be keeping track of instead of us as coroners.
Thank you. Dr. Farmer, Ms. Reed, thank you for joining us this evening. Appreciate your valuable testimony. We will move on to public comment online, if there's anybody.
Yes, can you hear me?
We can. Please state your name and we'll hear your testimony.
Okay, thank you so much, first of all. It's a long day, so I will try to get through this. So, good afternoon, Madam Chairman and members of the Joint Labor and Health and Social Service Committee. Thank you for the opportunity to testify. I represent Able Childs, a national nonprofit organization with a robust presence in Wyoming, where we have 50 members who are actively engaged. We have members in every state. Our reach has impacted thousands of families across the United States affected by psychiatric labeling and the dangerous psychiatric drugs. Our work has helped thousands of families understand the risks associated with psychiatric labeling and the psychiatric drug treatments. Our mission is informed consent and the right to refuse psychiatric treatment. This position does not impact those who choose psychiatric drugs. Psychiatric drugs prescribed to children and adolescents carry serious risks, including increased suicide ideation, suicidal behavior, violent tendencies, metabolic and neurological side effects, and in some cases, fatal overdose. Many of these medications have FDA black box warnings highlighting the potential for life-threatening consequences. Unfortunately, these dangerous side effects often occur without families being fully informed and offered safer alternative treatments. Able Child played a critical role in drafting landmark legislation in Tennessee that requires county medical examiners to test deceased mass shooters for prescriptions and psychotropic medications. This law mandates that therapeutic levels of psychiatric drugs be disclosed and shared with lawmakers and the University of Tennessee Health Science Center for Study. The goal is to increase transparency and accountability by revealing whether mind-altering drugs played a role in violent acts, such as mass shootings, thereby improving public safety and informing future preventative efforts. It is important to clarify that HIPAA protects individuals' identifiable health information about deceased persons for 50 years following the date of death. Very strange why it's 50 years. However, HIPAA was never intended to shield perpetrators of mass violence from scrutiny, nor to protect those who prescribe cocktails of psychiatric drugs off-label to young children or anyone for that matter from potential human rights violations. Moreover, HIPAA allows disclosure of protected health information to law enforcement without individual authorization under certain conditions. For instance, medical examiners and coroners may share toxicology test results with lawmakers as part of mandated reporting requirements. Disclosures can be made when necessary to alert law enforcement to criminal conduct or suspicious deaths. These disclosures are subject to strict limits, including provisions to release only the minimum necessary information relevant to the investigation, often under court order or subpoenas. This framework balances protecting privacy with the public interest in transparency and safety. Therefore, in the case of criminal acts such as mass shootings or any violent acts where people are harmed or killed in a public setting, such as malls, schools, churches, or public areas, this information on their drug use, including psychiatric drugs, should therefore be disclosed to the public. The public and lawmakers should not have to obtain court orders or freedom of information requests to have safety information released or collected. This law, which Able Child supports, the Wyoming Death Data Collection and Toxicology Transparency Act, is needed to start collecting critical data on the impact psychiatric drugs have on the public health system, enabling lawmakers and researchers to identify risks and allocate resources effectively to protect public safety. Lawmakers should not have to obtain court orders to receive this information. This law will strip the identification of the person from the data, and the aggregated information will be utilized by the state of Wyoming to protect human life. My suggestion is that an annual report are sent to this committee or to all legislators. Concerns about the cost of collecting toxicology data should not be a barrier to transparency or public safety. The cost of toxicology testing for violent deaths are not prohibitive. The law would not require toxicology testing for every death category, only for specific cases such as mass shootings and suicides. Undetermined violent deaths, toxicology is often already required. Many counties currently perform autopsies and toxicology as part of their standard investigative protocols. So this law would largely formalize and expand existing practices focusing on public health and safety. Wyoming needs to create a category to ensure that psychiatric drug results are tracked, to gather the data to help lawmakers make informed decisions relating to public health. Starting transparent data collection is a cost-effective step to better understanding the impact psychiatric drugs have on violent behavior and allocate resources effectively to prevent further tragedies. Currently, County
Ms.
Coroner,
Matthews,
yes.
Can you wrap it up?
Yes. You know what? I
your
submitted my
comment.
testimony. What I would like to do is a couple of things. The coroner mentioned that that the people, if they're taking their medication correctly, they wouldn't be dead. That is not an accurate thing to say. And in addition, we're not asking the coroner to do a causality report here. It's data that we're asking. In addition to some of the other comments, there are quite a bit of suicides. Actually, Wyoming is the highest suicide state in the country. We had, you have a combination, the public health director was there, and I liked some of his comments were very good, but you do have a combination of 2 years of data because of the relatively few cases of violent deaths. However, you had 8th graders, you had 10 suicides. 9 through 12-year-olds, 9th grade through 12th, you had 38 suicides. So you do have a crisis in the state, and you do have quite a number of suicides. So I don't think one or two, that argument doesn't really hold water for me or for our members across the country that have lost people to suicide. And I do want to say my heart goes out to the mom who testified. This is to save lives. I'm happy to answer any questions, but we are not placing, I felt that the coroner was taking a position that on psychiatric drugs of untreated as well as the psychiatrist, which begs to question how they can argue that all these people are untreated without any data collected on who's on psychiatric drugs and who isn't on psychiatric drugs when they commit suicide. And no, one other thing, no federal monies would be needed. It would not be jeopardizing federal funding because this would be something you do already in the state, and you would be just gathering information on the toxicologies and gathering your own data. Eventually,
Thank you, Ms. Matthews.
Sorry.
Committee, do we have any questions of Ms. Matthews? Okay, seeing none. Ms. Matthews, you said you did submit written testimony to the committee as well. So committee, I invite you to check your email and dive into that testimony if you'd like further information from Able Child. So thank you, Ms. Matthews, for joining us this evening. We appreciate your testimony. And Miss, are there any more online? Okay. All right. With that in mind, we are going to close public comment in person and online. Committee, you have the bill draft in front of you. What is your pleasure? Okay. Seeing a lack of a motion to move the bill has not been adopted. Again, committee, if there is no motion on a bill, that doesn't prevent any individual legislator from adopting a bill and bringing it forward as individual legislation. Just a friendly reminder of that. Committee, thank you for your good work today and on the bill. Ms. Johnson, am I forgetting anything on the agenda here?
Madam Chairwoman, I don't think so. If you'd like me to go
Okay.
through the bills that were passed and the other tasks, I can do that too, but that's up to you.
Okay, brief run through of the work of the committee, what's moving forward, what's been adopted by the committee would be appreciated. Thank you, Ms. Johnson.
Of course, Madam Chairwoman. So first off, we have 26 LSO 136, which is the pregnancy centers bill. That's going to be, that was moved for introduction. We also have 26 LSO 162, which was Medicaid coverage for birth centers. 26 LSO 135, which would increase the Medicaid rate for EMS. We're going to continue the naturopathic working group with the inclusion of Representatives Wasserberger, Gudmos, and Thayer, and Senator Crum. Regarding 26 LSO 169 Medicaid eligibility, that was sponsored. 26 LSO 140, the SNAP bill was sponsored. 26 LSO 137 hospital bankruptcy, and 26 LSO 141 unemployment insurance. Those were all moved for sponsorship. And that is the entirety of the committee's work this interim.
Thank you, Ms. Johnson. Committee, thank you again for all of your hard work these past 2 days. You are a very engaged committee, and I appreciate that, a hardworking committee, and I appreciate that as well. So thank you so much. The meeting has been adjourned.